Again, thank you for taking time out of your busy schedules to be here today. We have a pretty full meeting in store for you today. We have a couple of things, reports from state agencies from the legislative session, information that I think all our institutions will be involved in or interested in. We'll do our routine updates of the progress. A lot of progress has taken place over the last several months in rolling out the various programs, and want to make sure you're aware of that progress that's taking place. And then one of the most important things that we have is to approve the preliminary budget so we can start getting money out to you for the next 2 years. And again, we're very thankful to the Texas legislature for investing significant resources into the work of the Texas Child Mental Health Care Consortium. I think that's based on the work that you're doing in the communities across the state of Texas. So with that, why don't we go ahead and have our official roll call, and then we'll begin.
Okay, welcome everyone. I will start with Dr. Bobato.
Here.
Dr. Blader.
Here.
Danette Castle.
Here.
Dr. Chapa. Dr. Farmer.
Here.
Sonia Gaines.
Here.
Dr. Goodman.
Present.
Dr. Harper. Dr. Ibrahim.
Present.
I know Andy will be getting a link shortly. Dr. Lakey.
Present.
Dr. Liberzon. Dr. Martin. Present. Dr. Martinez.
Present.
Elizabeth Mayer. Dr. Mayer. Okay, Dr. McCullum Smith. She's a new member from
Hi, I'm here with Brittany. My login isn't working on my computer.
I don't think she has a panelist login.
Okay, we'll
in her
get that.
email.
Thank you, Brittany. So Brittany, I see you.
Next door.
Okay. I see you, Brittany. Dr. Mitchell.
Here.
Dr. Nemiroff.
Here.
Dr. Newport.
Here.
Dr. Pliska.
Here.
Dr. Podewelts. Scott Schlacklin. John Scott.
Present.
Dr. Suarez.
Here.
Dr. Taminga.
Here.
Dr. Thompson. Dr. Vo.
Here.
Dr. Wagner.
Here.
Dr. Wakefield. Here. Dr. Williams. Okay, thank you.
And how many EC members do we have? Twenty-two. So we're above quorum. Again, thank you everyone for taking time out of your busy schedules to be here. I'm going to move pretty rapidly at the beginning to get a couple things taken care of, but you have the minutes from the last meeting. If you would take a look at them, if there's any corrections, please let us know. If not, I'll take a motion to approve.
So moved.
Second. Second.
Ibrahim.
Thank you, Dr. Ibrahim. Any further discussion? Hearing none, all in favor signify by saying aye.
Aye.
Opposed, nay. Anybody abstain? All right, they're approved. If you have a computer in this room, just make sure that you have the volume turned off. So let's jump into item number 3. We're going to start off with Sarah McLaughlin to talk about the implementation of the ARPA funds. Sarah, I saw you up. You're right there.
Thank you.
Mhm.
Let's start presenting in Teams. Uh-oh. Okay, just kidding. I thought I didn't have sharing permissions. Perfect. All right. It's not full screen, but I think this is good for everyone. Hi, everyone. My name is Sarah McLaughlin, the ARPA project manager with the consortium. We're going to go over the ARPA projects from the last time we talked a couple of months ago. So this includes data through June. We'll talk a little bit about the operational procedures that have happened since then and do an overview of metrics and risks and actions. So the two main things that we have seen happen since the last time we talked are that we've held the ARPA project informational sessions. So that was hosted by the Texas Children's Mental Health Care Consortium and facilitated by HRIs who were participating in that particular ARPA expansion project. There we were able to go over best practices or any barriers encountered so that HRIs who are wishing to participate in these expansions for the next biennium have some good footing about what they can do to structure these programs for success. And then from there, we have had our budget meetings one-to-one with those HRIs as well. In addition, I have completed one-to-one project and goal review sessions with the HRIs and project leads to where we could look at the accomplishments and barriers so far and adjust any goals as needed based on project delays, staffing, or actual metrics to date. Through those one-to-ones and status reports and informational sessions, this is a summary of the primary risks that we're seeing so far and the actions that we're taking to address the risks that we're seeing. So the primary issue continues to be turnover or hiring difficulties for these roles. We have positions open and available, but hiring has been difficult. We have been able to review staffing models in the budget meetings with the HRIs. We've been able to explore additional employment benefits or perks that we can provide or encourage for our new employees that we're hoping to recruit. And we're also encouraging the use of interns and other provider types for a really robust program and to assist with some of those staffing difficulties. In regards to data, we have a combination of trait data and manual data that is being reconciled right now. So we're working with HRIs one-to-one to identify if there are any errors due to the collection so far. And we're looking over any missing reports. So I think with some of the turnover and hiring difficulties and status reports changing hands, a couple of things have been lost in translation, and we're making sure that we're picking up the slack there. So again, we're reviewing all of that data. We're going to be working on building the ARPA Power BI dashboard with the trait data directly to assist the HRIs and making sure that their numbers are accurate. And anything that's missing has been requested or escalated at this time. And then finally, the last thing that we're seeing are some issues with timing, and that's primarily with our CPW projects. We're going to be revising those goals based on timelines of the actual onboarding and make sure that that looks very accurate. So we'll review our three main programs. So we've got CPAN. This is an overview of the metrics I've received from the HRIs as of July 13th, 2023. 206 direct consults, 59 education sessions, 657 new providers, 476 consults, 262, consults via text, 262 consults, and 122 children reached initially by the collaborative care model. On the CPW projects, we are not quite in the therapist certified area of trauma-focused cognitive behavioral therapy, but we've got those courses completed and the consultation calls are in the works. We have 370 months of training provided under our CPW projects, 19,000 appointments and sessions provided, 6 community health centers partner with, and 4 residents trained in community health centers. And then finally with TChat, we've been able to provide 19,000 student sessions under ARPA, covered 100,000 lives, served a little over 5,000 unique youth. There are 24,000 youth receiving mental health education and training through YAM, 142 group sessions, and 304 providers trained under TChat. So that is our summary to date, again, through July 13th, based on what's been submitted by the HRIs. But if there are any questions or thoughts from the room.
All right, very good. Thank you, Sarah. Any questions? All right. Hearing none, thank you. Yeah, it's good to see the progress, and a couple projects still getting started, but the other ones that are moving forward significantly. So that's great. So let's go now to item number 4. We're going to discuss some information from the 80th Texas Legislative Session. We have several partners here today, and Sonia, it's great to have you here, and we have an update from you as the first item there.
Good morning, everyone.
We can't hear.
Can you hear me now?
Yes, thank you.
Good morning, everyone. Very happy to be here. It was a very exciting legislative session. I will say during my tenure over the last 10 years, this is the greatest amount of funding that we have yielded across HHSC in terms of mental health funding. And I'm really glad to have Trina in the room. We partnered with DFPS during this time, and she'll be able to share, some of those initiatives that will have an impact for children. So very quickly, and this is not an exhaustive list, I'm going to go through several of the things that really focus on services for kids. The first thing I want to mention, let me make sure I have this correct. So we do have some purchased psychiatric beds that were approved. Many of you know that we currently, in addition to our state hospital beds, there are beds that we contract for within the community. There's over 560 of those community beds currently. This last legislative session, there were an additional 193 community beds that were purchased. 70 of those will be rural and 123 would be in the urban area. 13.7 million of the dollars will go for inpatient beds serving the Uvalde community. We've done quite a bit of work with Uvalde and looked at, as a result of the shooting, what are some of the additional needs they have in terms of inpatient beds. And so those dollars will be set aside for them. And initially they will contract for some beds while a facility is being built. They're going to have a facility that will, it would be like a crisis stabilization facility, both for adults and children. There will also be 20 beds prioritized for children in the DFPS conservatorship. And I know that Trina will touch on that. We will also have some crisis respite units for youth, 5.7 million in each fiscal year. 4 additional crisis stabilizations that will serve youth. We're still needing to get some clarification on, we had one initiative that was funded for a pilot for 3 peer-run units, and they're supposed to be for children, but we know that we don't have there's no such thing as peer-run respite units. So we're seeking some clarification on that one. Another area I'm very excited about is the youth mobile crisis teams. And this gives us an opportunity to have $7 million in each fiscal year, which will allow us to develop 7 new teams. And this includes 3 MCOTs for children that will be served by the DFPS population. Under multi-systemic therapy, there's 15.2 million in each fiscal year to expand MST. Coordinated specialty care, 2.1 million in each fiscal year to expand coordinated specialty care. That's one that we have, pretty much across many of our local mental health authorities today. We're seeing a lot of positive outcomes related to that program. So we're very excited about that. And Rider 56, rural hospital telepsychiatry consult, 3.7 in each fiscal year to fund telepsychiatry consultations for rural serving hospitals. There's also an initiative for the development of a statewide behavioral health strategic plan for children. And I know that Luann and other other parts of the consortium are involved in that, as well as some of the other state agencies. The plan will incorporate the full continuum of care needed to support children and families, and include descriptions of who provides the services to which children, strategies to identify and address gaps in care, discussion of workforce shortages, information on funding and reimbursement, children-specific data and expenditure information. Statewide Behavioral Health Coordinating Council will form a subcommittee to develop the plan. So we're very, very excited about that. The other thing I want to mention, and I'm just trying to make sure that I cover the things that are child specific. We're also very excited about some expansion dollars that we received that will allow us to expand some of our grant programs that many of you are familiar with. House Bill 13, which is a grant that will allow communities to provide proposals related to mental health needs. Sometimes these are unique needs that they may be seeing in their community. So that's 30 million over the biennium. I'm sorry, 15 million over the biennium. The 30 million expansion is for the justice involved grants. And that's Senate Bill, what many of you know as Senate Bill 292. So we're excited about that. Then there's an $8 million increase over the biennium for the Healthy Community Collaborative grant for a total of 33 million that will now be assigned to that grant program. Another area I want to touch on, Senate Bill 26, CoCourse was the author. The first one is to allow flexibility for the local mental health authorities to hire staff for children mental health, behavioral health partnership. Some sessions ago, there was a piece of legislation that required that the LMHAs partner up with the education service centers. And they've been working very well together, which has yielded some really positive things. But one of the things that we're finding, particularly in the rural serving areas, they're having some difficulty hiring the level of staff, like the licensed staff that were required in the legislation. And so this piece of legislation will allow there to be a waiver request when they are having difficulty and they can hire a lesser education level. So we're really excited about that. I know that seems like a small thing, but for the rural serving areas, that is very, very huge. Also, there was something called the joint discharge planning with the state hospitals and the local mental health authorities. State hospitals will receive funding where they will be able to hire transition specialists in each facility to facilitate joint discharge planning with the local mental health authorities and prioritize patients with high needs. We think that that's going to help individuals transition and maybe get to the services that they need and stay in the community. I'm trying to think, the other one on here is the Innovation Matching Grant Program for mental health and early intervention and treatment. That program will actually be operated by our family health services. A decision was made to put that in an area that is doing much more broader support to families and children. And so we're really, really excited about the opportunity with that. There will be 30 million in general revenue funds for the biennium, $15 million annually to promote the identification of mental health issues and improve access to intervention and treatment for children and families. So that's a brand new program that's focused on children and family. And I think those are the high points related to the children focused initiatives and funding. Any questions on that?
Very good. Any questions for Sonia? Yep. Click there and it's green. Now you can talk.
There you go. Just a comment. I don't know, I came a little bit late when you were in the middle. We also got a separate bill together with Children Hospital Association of Texas and in coordination with coordinating board to do 2-year study of the inpatient continuum needs for the children in Texas, children mental health in Texas. And that came to us as a part of this process. And we're already working with coordinated board and the Children's Hospital Association of Texas in developing a study. And I will actually planning to maybe ask some of the people here to join the advisory group for that. It will be mostly epidemiologists and health services researcher, as well as child psychiatrists who will be involved in the Texas A&M side for that.
Excellent.
Who is that, David? Who made that comment?
It's me.
That was Israel.
Oh, hi, Israel.
Hi, Carol.
And a quick to my team. It sounds like Dr. Polderwitz is trying to get in and is having difficulty. So the folks in the back, if we could send him another link to help him get on, that'd be great.
This is Cheryl McCullum Smith, and hi, Israel.
Hi, Carol. Welcome to Texas.
Thank you. Being new here, at some point, hearing all of the legislation bills, it's really exciting. But at some point, I would like to know which ones are available for us to apply for and which ones are already earmarked for certain funds. But if that's already done, forgive me, but that would be really helpful for me.
So let me just go back through the ones that I mentioned under Rider 52. We actually issued what we call a needs capacity assessment, and that was actually issued on last Friday. I'm really pleased that the staff have really done a lot of prep work during the session, in part because we kind of knew early on, decisions were made, pretty early in the process. And so with the needs capacity assessment for the Rider 52, which includes the crisis units for youth, the crisis stabilization units, the youth mobile outreach teams, MST, coordinated specialty care, those things will be available for the local mental health authorities to apply for. But I will say this, that we are also encouraging our local mental health authorities to partner when, they don't have the ability or to, stand up some of these programs. For example, we have, I think it's over 15 new MST teams, if I'm not mistaken. So there may be opportunities for, others to partner with the local mental health authorities when it comes to those type of services. I do want to stress, and I shared this with Dr. Lakey before coming in. One of the things we want to make sure is that we build on our system of care and that we don't create fragmentation. And so many of these services, particularly MST, coordinated specialty care, these are time-limited programs. These are not, forever programs. So it's going to be important that there is, a good handoff for the ongoing services. And so that's why it's really important, we're really encouraging the partnership and the collaboration. And so, that's why we're doing these programs in this fashion. The other thing is that there will be some opportunities through RFP processes, particularly with House Bill 13. I mentioned the new dollars that will be available for that grant program, along with the other grant program, the Innovation Matching Grant Program for children. So those are two grant opportunities that, there will be a formal RFP that will come out and, individuals that are qualified or areas that are qualified. And there'll be a selection process to determine, the best programs. And then we will also, pair that up with some of the gaps that we, may be aware of. And those gaps may exist through, strategic planning that we've already done. Luann participates with the coordinating council. There's some other subcommittees that have identified some gap areas, and we can also see gap areas through data that we have where we know there's a prevalence of challenges, that sort of thing. And so, there will be opportunities particularly with those grant programs through RFPs.
All right, very good. Andy, I see you've been patiently waiting with your hand up. Let me go to you next.
That was my patient face. I didn't know that. I'll have to reuse that again sometime. So a great overview, and that was a great question. Thank you so much for doing that. I just want to say, getting that out so fast on Friday, that's amazing. And I really want to emphasize, just underscore what Sonia said about the MST teams, the youth crisis outreach teams, and I think also maybe even for the coordinated specialty care teams, that these are opportunities to work with your local mental health authority partners and build out that system, because local mental health authorities, they're the authority to coordinate a local system of care. And so by building those partnerships, often they are the best providers of that care. Sometimes though, there are hospital providers, you all as university providers sometimes can be partners to do joint programs. So the more you all can reach out to your local mental health authorities and talk to them, and be part of that planning and make sure they know what resources y'all have so they can have that in the mix. It's also really important for TChat referrals to come back, because TChat referrals, just like some of these other short-term programs, need to be referred back often, not always, but often, to local mental health authority partners. So this is just a great opportunity to continue to build out that true system of care. And it's really good. So Sonia, thank you so much. I mean, you guys got that out so fast. And I think it's important that both the HRIs on the call, but also the hospital partners on the call, do you have anybody who is potentially able to help? Because with the current workforce issues, we need everybody pitching in together. And I think the framework y'all put out was fantastic. So Sonia, thank you for making that happen. Or Deputy Executive Commissioner, thank you for making that happen. And let us know if we can be supportive to help anybody with that.
Absolutely. And Dr. Lakey, if you don't mind, I should have said this at the very beginning, but there was a lot of work that went into materializing all of these new resources. And many of you that are on this call or sitting around this table today played a huge role. I know I was in hearings with some folks, and even during conference committee, I know Trina and I saw each other almost every day. And so, I just want to say thank you, Texas Council, Meadows, Dr. Lakey and team, and those of you that really played a huge role in getting the message across about what the needs were. And I think that message was heard. We were a strong, united front, and I think that played a positive role in materializing these new resources. And I'm very, very grateful, very thankful. Thank you.
No, I think that's a good point. And I think we need to make sure that the legislature understands how grateful we are for the investments that they put in, and that the agencies, our institutions are going to be good stewards of these dollars. There's always that perception. And Andy, I've heard you address it well during legislative hearings about that perception of the investment in Texas. And the reality is the legislature has put in a lot of money over the last decade to try to improve the mental health system in a state that's growing very rapidly, has ongoing needs. But again, the legislature has been investing significantly for at least I know 15 plus years as we've tried to improve services across the state of Texas. And that story gets missed a lot, and is one of the stories we need to make sure people understand so that they'll continue to invest and move forward.
Yeah.
All right.
Yeah, David, I would also add in the university presidents, and the institutional commitment of the consortium members was huge. So I think both y'all as your department chairs and certainly your active leadership, but your institutions being behind this also was a huge reason why all that happened. And I wanted to, so thank you for reiterating that. David, can I ask Sonia one more question? Sonia, can you just tell us what's the due dates? Because I think it's pretty soon, right? Like a month or something. Like when do the LMHAs have to put in their needed capacity assessments for folks?
Yeah, great question, Andy. 5 weeks from Friday, last Friday. They have 5 weeks. And unless something odd occurs, sometimes we've had a hurricane or some disaster that has had an impact, and then we're flexible with it. But we're trying to. We have, as you can tell, we have several things that we have to get done, and it's the same group of people that are doing all the work. So 5 weeks is what we're giving. I see Danette has her hand up as well.
Yes, I do have my hand up. I just felt like I needed to step into this conversation a bit because, of course, the local mental health authorities are looking forward to the opportunity to continue to improve the mental health service system in Texas. And so I would say to you, Dr. Lakey, yes, how important it is for us to ensure that we are conveying gratitude. And I would also say it's not just because we're trying to, it's because we are improving mental health service delivery in Texas. It is a hard row because we are making up for a lot of lost time in which those investments were not incurring in the way that they are today. And then, of course, we've got workforce challenges that are much greater than they were previously. And I would just say that our anxiety is running high. And there are some moments where I feel a little bit like the emperor has no clothes from the standpoint of we really, in order to deliver, have to be able to translate these resources to actually touching people. And that takes a workforce. And we are highly concerned about our ability to meet the opportunity here in a way that we all want to. I hear that as a common thread. It's a thread for the TCHAP program and everything else that the TCMHCC consortium is involved in. So we have to pay attention to that. We're also going to need to really be paying attention to the outpatient treatment component of service delivery. There's a lot of focus right now on inpatient, alternatives to institutional care, alternatives to hospital, and very specialized kinds of services. We also need to ensure that along the way, we don't forget that ensuring that access to outpatient treatment at the first moment that somebody shows that they need treatment is really important and vital. And if we're able to do that and do that well, then we can lessen the need for more specialized services down the road. So that's just something for us to be paying attention to in the future. We will look forward to our continued partnership with the HRIs across the state and hope to continue to develop that. And I just would also say that we appreciate Dr. Lakey and Dr. Keller and the agency for their effort to address the workforce shortages in our system. We would have liked for it to land it at a higher level. But we are at least grateful for some funding that basically acknowledges the need to really develop and invest in the workforce of mental health service frontline service delivery.
Very good. I think you've perfectly teed up our next speaker. Is there any other questions on this issue before I transfer over to Elizabeth Mayer with the Texas Higher Education Coordinating Board? Hearing none, again, thanks, Sonia. And Elizabeth, you've heard all these workforce issues, and you're right in the middle of it. So why don't we go?
Yes. I'm going to go ahead and share my screen. I pulled together a PowerPoint presentation to help give you guys a sense of kind of where we're at. Let's see here. Right. All right. Can you all see my screen?
We can.
Okay. So what I'm going to do is go ahead and give you an overview of the funds that the agency received. It's going to be a little bit broader than just mental health. I really think that because of how the healthcare system works, even some of the programs that aren't directly related or intended to maybe support the mental health workforce, I think there's this information will still be valuable for you all. So in terms of the consortium, you guys have likely seen this before. You received about $280 million for the biennium. You can see the breakout here that is provided in the rider. I don't think any of this is likely a surprise for you all, but you can see the breakdown by each of the specific programs. I also did want to point out that for the ARPA funds, there was an extension. We are currently working with our Office of General Counsel right now to finalize that amendment. And those funds will likely be extended until the summer of 2025. Looks like June at this point. So just wanted to let you know all about that. And then I'm going to run through some of these other programs that I think many of you are likely familiar with, but just want to give you some details. Most of these, I think every single program received an increase for the biennium. So the GME program expansion, this program was established in the 83rd Texas Legislature and initiated several new programs to address the shortage of first-year residency positions. The initial effort, which started in fiscal year 2014, appropriated more than $14 million and has expanded to approximately $233 million for the 24-25 biennium. I also would like to note that for the 22-23 biennium, about 64% of funds were for primary care and 36% were for other specialties, but I wanted to call out about the 16% that were included for psychiatry. The Family Practice Residency Program has existed since the 70s, and that funding amount has fluctuated over the last several years, but they did receive an increase this biennium of a total of $16.5 million. The Joint Admissions Medical Program, or the program known as JAMP, this was established as a medical school pipeline in the 77th Legislature in 2001 to support and encourage highly qualified economically disadvantaged Texas students pursuing a medical education, and the amount of that funding has remained relatively stable, but did receive a slight increase of $11.7 million for the biennium. The Emergency and Trauma Care Education Partnership Program was also established around the same time as the GME expansion program to help support that 1.1 to 1 ratio. The funding has been declining since its peak of funding in 16-17, but did receive a slight increase from the last biennium of a total of $5.9 million. The Professional Nursing Shortage Reduction Program, or NSRP, was created by the legislature in 2001. The program provides grants to nursing education programs at Texas public and private, as well as nonprofit institutions of higher education, to increase the number of licensed nurses through investments in enrolling, retaining, and graduating nurses. This received quite a bit of an increase for a total of $46.8 million for the biennium. The statewide preceptorship program, which is intended to help support students to potentially determine on a primary care specialty or residency as they're finishing up their medical school. They didn't receive any funding for 14-15, but the last couple of bienniums have received some and did have an increase of $4.9 million. And then these last two programs are tobacco funded. The Minority Health and Research Education Program provides funding to eligible institutions to conduct research and educational programs on public health issues affecting one or more minority groups in Texas. And then lastly, the Nursing Allied Health Funds, and these are used to address really the nursing shortage. This was established in the legislature in 1999, and as I said, the tobacco funds support this and received $3.7 million. Okay. And then next, I also wanted to highlight some new programs that either had never been funded before or just going to be completely new. So this first one is the Rural Residency Physician Grant Program. This funding includes $3 million for the program. And this was established in the 2019 session, but was never funded. For all of these programs, we're working through the details of what the program is going to look like moving forward, and if we're going to have to establish rules for them. The second program that you all are likely interested in is the Forensic Psychiatry Fellowship Program. This is actually a new program doesn't have any corresponding statute. Currently, there is one program, I believe, at UT Southwestern to support this. So I think this is intended to potentially expand that, since there's only one program in the state. The next is the nursing scholarship statute, or the nursing scholarship program. So this has been in statute actually since 1989, but as I understand, has not been funded for quite some time. But they received $25 million this legislative session, and there was some cleanup, I believe, in SB 25, clarifying some of the details for that program. And then lastly is the Nursing Innovation Grant Program, which receives $6 million. And like I said, this one is also another one where there's not really a corresponding statute that we're aware of. And so we're going to go and get some information and background about what this might look like moving forward.
And Elizabeth, if I may jump in real quick, on the Forensic Psychiatry Fellowship program, my understanding it is to expand or create new fellowship programs. And so even if you're not UT Southwestern,
yes,
UT Southwestern will be in a good position to expand that, but there is an opportunity for other programs across the state to develop new forensic programs. And this is going to be the topic for the chairs of psychiatry meeting that we have coming up. We're going to have some of the people that were involved in putting it together and trying to put that together with our thoughts with people from the Higher Education Coordinating Board on how those dollars could be best used. So thanks. And then let me let you could continue with your slides, and then Joe, I see your hand up, and we'll go to you after Elizabeth finishes.
One more slide. Okay. So also, I wanted to point out that these educational loan repayment programs also receive some additional funding. So the purpose of the Physician Education Loan Repayment Program is really to encourage qualified physicians to practice medicine in a health professional shortage area as designated by the U.S. Department of Health and Human Services, and really to provide healthcare services to recipients under the Medical Assistance Program authorized by the Texas Human Resource Code, Chapter 32. In the primary, approved primary care specialties, so with the exception of psychiatrists and geriatricians, physicians must provide services in an outpatient setting to be considered primary care. But this list includes family medicine, general practice, OBGYN, general internal medicine, pediatrics, psychiatry, and geriatrics. And then the mental health loan repayment program also received a significant increase. And the purpose of this is really to encourage, same thing, qualified mental health professionals to practice in a mental health professional shortage area, and to provide mental health care services to recipients under the Medical Assistance Program authorized under the Human Resources Code, Chapter 32. So the award amount depends on the specific kind of specialty, but the eligible practice specialties are psychiatrists, psychologists, advanced practice nurses, board certified in psychiatric or mental health nursing, licensed professional counselors, licensed clinical social workers, licensed marriage and family therapists, and licensed chemical dependency counselors who have earned an associate's degree related to chemical dependency counseling or behavioral science. So that concludes my presentation. Happy to answer any questions. Just wanted to provide you all a overview of kind of where we're at this point with the funding for the state. Like I said, for several of the grant programs, particularly the new ones, we're going to go through and look at what rules need to be developed, working very closely with our general counsel's office to see kind of what that looks like moving forward. And Dr. Lake, I'm going to hand it over to you to field questions.
All right, very good. And again, thank you, Elizabeth, for your support of all these initiatives. And the Higher Education Coordinating Board has been a very strong supporter of the work that we've been doing through the consortium. All our funds come through them, and it really is a partnership. And it was, I think, rewarding to see some of these things that we talked about with the legislature to be actually put into programs. And so there's dollars related to loan repayment and a variety of things. And so that's exciting. Joe, let me go to you. And again, please feel free to raise your hand if you have a question.
Well, thank you very much for that report. That's great. I just had a quick clarifying question as to whether the GME funds, are you presenting only what's authorized to flow through universities, or is that inclusive of?
This is just the grant
entities?
program. This is not the like formula or any of that. It's just the GME expansion grant program.
But, so for instance, hospitals that support residencies that aren't.
That, I think that's
university
separate. I think that's all
affiliated.
separate.
Oh,
Yeah.
okay, great.
Yeah,
All right,
yeah,
thank you very
yeah.
much. Thanks.
Any other questions? Seeing none, again, thank you for being here and for the presentation.
Thank you.
Quick little check, Luann. Several people have joined us since we did the roll call. Dr. Liberzon Israel joined us. I think several people online. Just want to make sure our record is straight. Can you just double check on some of the names?
Dr. Keller? Andy?
Yes, here.
Dr. Liberzon?
Here.
Elizabeth Mayer?
Here.
And Dr. Potter Wells.
He's there.
I'm here.
And did we have Sarah Wakefield in the first?
Oh,
She's
Yes.
clearly here.
I was here. I called here when y'all
Okay.
called my name
Just
first.
want to double check.
Yes,
All right.
no, I appreciate it.
Anybody else that we didn't recognize you at the beginning? If no, we'll go ahead and move forward. And it is my privilege to introduce a friend, somebody's had the privilege of working with for several years. Trina Ida, she is the Chief Strategist for Behavioral Health Commissioner and part of the Commissioner's executive team at the Department of Family Protective Services. Prior to that was one of the key people working with Sonia at HHSC. And again, it's great to have somebody that knows children's mental health needs now at the Department of Family Protective Services. And we thought it would be good to give her an opportunity to update everyone here about the work that they're doing now at DFPS related to kids, because it really impacts the work that we're trying to do. So Trina, great to have you here.
Thank you, Dr. Lakey. Good morning, everyone. I wanted to thank you, Deck Gaines, for the information you provided. I think much of what I think will be impactful to DFPS and the kids that are in conservatorship are being administered at the Health and Human Services Commission. And as Deck Gaines mentioned, we work very close together during this legislative session to really identify what we thought would be important in terms of rounding out the continuum of care. And so she highlighted some things where we had some really good success in relation to initiatives that will be supporting youth, both in preventing them from coming into conservatorship and stabilizing those that may be in conservatorship already, and addressing the needs of those that are in conservatorship. I will draw your attention back to YCOT was one of the things she talked about, which was a very important initiative that they'll be operationalizing at Health and Human Services. And so we are in close collaboration around that work, really to have a strategic statewide approach to how that particular initiative is administered, as well as we got 20 beds dedicated to DFPS out of the private psychiatric beds that Deck Gaines mentioned. And we're working closely with the commission to really identify the criteria and how to get those beds deployed as well. One thing I want to draw you all's attention to, which is really kind of a shift for DFPS, because as you know, DFPS is a child protection agency, and that has been really the core of what they do. But I think over the years, there's been a recognition that behavioral health and addressing needs from a behavioral health perspective has perhaps been a gap in a way, right? And so there's been a really targeted effort and, to really try and, I think, address that chasm. And so part of this legislative session, what was funded was an inaugural team to focus on behavioral health from a more strategic perspective, working at the department, which is this role that I'm serving in as chief strategist for behavioral health, as well as a team of folks to focus on that coordinated approach and strategic approach in addressing the needs of kids in conservatorship. And so that really, I think, engenders that close working relationship with the Health and Human Services Commission, as well as other child serving agencies such as JJD, TEA, et cetera. One of the things that we just concluded was a host of listening sessions where we brought together stakeholders to hear, first we had a panelist of experts from from the various child serving agencies, Health and Human Services Commission, JJD, TEA, the Children's Commission, the Judicial Commission on Mental Health, to hear from stakeholders what they perceive the gaps and challenges were in relation to behavioral health gaps for children in conservatorship and just the continuum of care in general. And so that will culminate into really what sets the foundation for this office that I mentioned, this inaugural office of the department, as well as, some of the other things that are directed legislatively. There is a rider 44 that requests or directs the reporting out of activities and outcomes of this team at the department. And so the work that we do in collaboration with other child serving agencies, as well as the initiatives that were funded through this legislative session, are things that we'll be talking about in terms of activities that support youth in care, or those kids that are in need of services from the behavioral health continuum. In terms of timeframe, I think Dec Kane's already kind of outlined, that for YCOT. And with that, if there are any questions folks might have in terms of this inaugural team or anything else, I'm happy to answer that at this point in time. Thank you.
Very good. Thank you, Trina. Any questions from anybody?
Just have a comment. One of the things that I wanted to mention, I've been very excited that my team, along with Trina's team, have been working very closely together to look at the data on, again, where some of the challenging points are that we're really having a lot of stress in, children that need more support than what they can get from traditional outpatient settings. And so through that data, that will, direct us in terms of where we want to put the resources. And we're hoping that we get some early outcomes before the next session so that, we kind of set the groundwork for more, because, just having 7 YCOT teams is not going to be enough. And some of the other resources are on a smaller scale. So we're hoping that, we do a good job and we can, demonstrate the benefit of these services. So really excited about the partnership and super proud of Trina, who came from our behavioral health program area. She's done a great job.
Thank you, Dec Gaines. Any questions?
Oh, okay. Sarah, then we go to you, and then Andy, you're next.
Hi, yes, I was wondering, and you may not be able to do this just yet, but if you could outline for us or kind of give an overview of the collaboration you see with juvenile justice too. I'm imagining YCOT and DFPS and juvenile justice, or for the juvenile probation office. There are a lot of overlap there, and wondering if you were having those continued conversations or plan to with the Justice Department.
I would say the latter for sure. I've had some conversations with Dr. Lepore. He was one of the listening panel experts. And so I'm imagining from the information we gleaned from those listening sessions, we also did a SWOT analysis, strengths, weakness, opportunities, and threats analysis prior to the listening sessions to get feedback from stakeholders about what they perceive the gaps to be. And so, I imagine there will be conversations to be had and some strategy planning, in particular with JJD. We're seeing some interesting things, in terms of kids who maybe historically have been part of JJD that are coming into the DFPS system. And so the short is yes to your question, that I do see collaboration and work on strategy to try and address any gaps that exist for those youth.
Very good. Andy?
Yeah, thanks, Trina. That's fantastic. And again, I joined Sonia in commending you and DFPS for creating the position. It's just fantastic. I think this also underscores, though, something that Deputy Executive Commissioner Gaines said in her presentation about the work with Luann and others to put together the children's strategic plan, because I think that's really what we've been lacking as a state. And I think that's going to have to then encompass not just state agencies, but also these important county agencies like the Juvenile Justice the county juvenile justice providers, several of whom, I mean, one of which currently has MST teams, several of which are looking to add MST teams now, and hopefully will do so in the vein that Harris County has, where there's really strong collaboration between the local mental health authority, who actually provides one or two of their teams, and the county. So I think this just creates more opportunities to knit together a system of care. It also, I think, creates opportunities to have a much richer array for our TChat referrals, that our TChat referrals being able to go out, being able to have a full sort of knit together array of care. And I think it's also important too for the HRIs to think in turn about both the contractors that work with DFPS as well as the local mental health authorities, as you all are thinking about your TChat capacity and the ramping up that you're going to do with that wonderful budget presentation that we were all celebrating a while ago. Because the workforce is going to have to be one where we work together and not just where we try to ramp up within our individual silos. So I think your efforts, Trina, super appreciated. The commissioners of DFPS, the HHSC's efforts through Sonia, along with the HRIs. This is just an unprecedented opportunity for us to not just do more, but to do it in a more coordinated, impactful way in partnership with these community partners. So I guess I wanted to just say that, Trina, but if you want to comment on that, I'd love to have your thoughts on it.
Yeah, I appreciate that feedback. As you were talking, I was thinking about, I was remiss in not even talking about, the agreement, the MOU that we have with Meadows right now to really look at benefits maximization with the Star Health benefit. As you all may know, children in conservatorship are entitled to the Star Health benefit. And so there's some work there to really make sure there's a maximization of the suite of services that you have access to right now. But to kind of echo what you mentioned, Dr. Kello, I think this is a great opportunity to really have a coordinated approach, a strategic approach to addressing the needs of youth across the continuum, whether they're in conservatorship or not, right? Wherever that need presents. And DFPS will be participating in the development of that children's mental health strategic plan. I know that work is already underway. The listening sessions that I mentioned, dovetail right into some of that work. I've been in communication with Dr. Harvey, who works for Det Gaines in the Office of Mental Health Coordination. Her team is leading that effort around the building of that strategic plan. And we've had some intentional conversations around what's gleaned from the listening sessions and then the work that will be forward after that in relation to how we do that coordinated work and planning around building a strong continuum for youth in Texas. So thank you for your comments.
Very good. Steve Pliska.
Yes, I actually had an acronym I not heard. YCOT. Could someone tell me what that stands for?
Yes, Youth Crisis Outreach Teams.
And just briefly, what do they do?
So if you're familiar with MCOTs, which are mobile crisis outreach teams, very similar to that, but this is more focused on youth and families. And it actually has I would say a period of time that family and youth are followed after a crisis is identified. I think as we're talking about the development of it, there's a window of time about 4 to 6 weeks post the crisis that's been identified where they could be followed by that YCOT team and provided some supports and things to really stabilize and maybe even do some skills training and teaching to the family to support that youth to abate crisis that has been identified and why they may have been deployed in the first place. So in some ways very similar to an MCOT, right. But with more focus on the youth and families.
And that's a program of the LMHAs?
Yes, that's correct.
Okay, great. Like MCOT itself.
Yes.
Okay, got it. Thank you.
I think it's important to mention that we have not all LMHAs have these teams. We got 7 new ones, and then we had a few other ones that were funded before session. But again, we're hoping that we see great outcomes with these programs that were funded on a limited basis, that we can expand and to make a system of care across the state. So that's one of our goals.
I think that's an important point because while MCOTs are operational and functional today, YCOTs have to get there.
Very good. Any other questions or comments? All right, hearing none. Again, it's great to have you here. Look forward to figuring out how we can work together and hear continued progress of these initiatives before we get to the next session. That's great. All right, let's transition now to item number 5. And the first presenter is me. And let me discuss a little bit about the new and emerging Children's Mental Health Researchers Initiative. At our last meeting, we gave a presentation on the initial thought process related to this program. There was a lot of good discussion that took place. I tried to take that discussion and incorporate it into the next version of the document. A couple of you, I had continued conversations. It looks like with afterwards, we have about $4 million, a little bit more than that we'll be able to invest. Again, one of the key purposes of the consortium, the 5th mission is to try to improve where we are related to mental health research in the state of Texas. And I am increasingly being convinced the only way we're going to move up that scale is if we invest in young faculty and junior investigators and trainees and get them to where they can get their first NIH grant, which takes a lot of preliminary data. So I appreciate everyone's input. Again, we shared this document again early last week. Why don't we, Lachelle, go to preliminary, the purpose on second page. And I'm not going to read this whole document to you, but again, I just want to make sure you know that I incorporated the feedback that you provided us. So the purpose of this initiative is to foster, encourage, and mentor junior researchers and trainees at our institutions so they can secure extramural funding focused on improving mental health systems of care in Texas. We have the preliminary guidelines. The purpose will be focused on research topics identified. And Sonia, we put in this working with HHSC related to what some of the major challenges are with the groups that you work with in partnership with this executive committee. That those proposals would focus on improving the mental health systems and services in Texas, and that may include gaining an understanding of the causes of childhood psychiatric disorders. Again, to be consistent with our conversations with the legislature, we've noted that basic bench research and pharmaceutical clinical trials wouldn't be eligible for this funding. And again, the proposals are meant to enable our individuals after a one-time grant to be able to then obtain extramural funds. On the eligibility, we had a lot of discussion about this last time, that we needed to be careful that we didn't make it just very junior individuals if we really needed to move our institutions forward, that there are individuals at the associate professional rate that haven't had an R01 grant before. And so we broadened that definition to make it eligible to those individuals. We have a line there related to trainees, including clinical research fellows are eligible. A lot of discussion last time to make sure that trainees would be eligible for this funding. And again, number F there, that we would encourage individuals to work across institutions and in partnership. Item number 3, I reworked this based on the conversation that we had last time. Kind of what I heard was a one size doesn't fit all, that we needed to have a couple of different types of initiatives, a research career development award, $100,000 per year for salary, $50,000 per year for projects for very junior individuals. The research project grants, again, at $250,000 per year. So that'd be a total of $500,000 for the duration of the proposal. And a clear cutout for postdoctoral fellows and trainees, eligible for $75,000 per year, or $150,000 in total. We will limit the indirect costs to 15% based on this type of research, but also put in that mentors could receive up to 5% salary support. But also put in there the NIH cap. And again, I just want to be careful that we don't put too much money into that category. In the selection process, we will have an independent peer review committee consisting of researchers based outside the state of Texas to make sure that we can address conflicts of interest. We will work with this group to appoint those individuals. The committee will review the candidates and research proposals and then make recommendations, and that there is or will be some funds to reimburse those individuals. But the final decision-making authority would be in this committee and the executive committee. And because there are some balances that we need to do in order to make sure that that we encourage research at all of our institutions to the extent that we can. We also included the mentoring program here. And again, I'm not going to read through that, but the goal here is to make sure the people that we put money in have the opportunity to work with investigators across our state and the peers that we're funding, so that we help them get to the position where they're going to be able to bring in the NIH grants. So that's the basic summary. Israel, I see your hand. Let me go to you first for any questions or comments.
Yeah. First of all, I can't be happier. First of all, I say I cannot be happier. I think it's an excellent program. It's a great idea, and we definitely should do it. The only small comment that I have, I think that postdoctoral fellow category should be expanded, including fellows, psychiatric fellowship programs participants, so residents and fellows, and not only postdoctoral fellows. So to me, that's just expanding. The other thing that we should just think about it, so there are some people who are in institutions who are involved in a clinical care mainly. Some of them actually have a capacity and interest to expand into the health services, another area that would like to encourage them. So how to encourage our clinical faculty who are interested actually to join hands and work with us on a research project that should be also at least reflected in this statement.
Yeah. And Dr. Liberzon, I don't think those individuals are excluded the way that I've written it. At least I've tried to. And so that will be part of the selection committee. We'll be able to go through that, but we've tried to throw a broad net and then allow that selection committee go through the process. One of the other things I heard from this group was to make sure that it's not only based on the proposal, but the people, and that we try to encourage the people. I'm going to go to Dr. Nemroff, and then Jeffrey, I'm going to you. My goal here is to get to good enough. And that it may not be perfect, but it's a document that we can work with to move things forward. And because there's going to be a lot of work to get a peer review process and all those type of things set up. So Charlie, you, and then to Jeffrey, and then Carol.
So let me applaud you, David, for working with us on this project. And I couldn't be more excited about it. I just want to highlight a few parts of it. The goal, the output of this project, the metrics which its success will be judged, will be on whether these young people who we provide the equivalent of a career development award or a fellowship go on to obtain NIH funding, and as such, end up increasing the corpus of funding for the state of Texas from NIH. And so that's our goal. I think we're very open to the idea that the professional background of the individuals can be quite varied. These could be PhD psychologists, nurse practitioners, as long as they are affiliated with one of the academic departments. And, I think Israel is correct in that very senior residents in transitioning to a faculty position would be eligible for the fellowship, for example. And Israel is also correct in that there are some great clinicians who are associate professors and have always wanted to do research, but never had the opportunity. And this will give them that chance, right? So I think it's fair to say that, even if you've had a little piece of an NIH grant, if you haven't had your own R01, yep, you are eligible for the program. So cheers to you, David.
No, thank you. Jeffrey?
Yeah, I wanted to get a little bit of clarification on the scope of research projects that would fit under this. It's clear that we're talking about child mental health, but then adding some definition to that, in particular, what's the age range on the top end. But my own selfish interest is what's the age range on the bottom end, and I'm particularly interested in terms of this field now known as infant mental health. which we're talking about from birth to 3 years of age, obviously well before any diagnosable mental disorder. But the reason I'm posing that question is often those infant mental health studies are really kind of focusing on, parent-child interaction and how that affects child development and we may or may not need to spell all of this out in the scope of what's written, but I'm just curious as to what everyone's thinking about the scope.
I've tried to write it broadly. And we, Charlie and I had a little bit of this discussion before, and I think I need to make sure that I write it broadly and let the selection committee. I also need to make sure that this is GR dollars. And so I need to make sure GR dollars are spent according to the statute that guides those GR dollars, which are a little bit different than the ARPA dollars. And so I think it's best if I kind of keep it kind of in the language I have right now. But the statute doesn't allow me yet to put it into adult mental health research. It's GR is based on children's mental health services, at least the way it's written right now. Now, I think we have some flexibility there, but that's going to be a little bit of working with individuals to make sure we get to where we can feel very comfortable that we're aligned with the statute and authority we have for the dollars. Okay. Does that make sense?
David, we will catch some adult mental health researchers interested in applying, their paradigms to pediatric mental health. I think that would be applicable, wouldn't it? If
adult researchers that are interested in improving the children's mental health system in the state of Texas, the causes of children's mental health, that's fully eligible for these funds, the way that I understand that we've written it. Okay. Carol, I see your hand, then Karen, and then Brittany.
So, David, this is a fabulous proposal. From my point of view, it will help keep our best researchers here in Texas instead of sending them to other states to do the same thing. So I think it'll really do one of the things that we want most. I would just make one small suggestion, and that is when you said that all of these would be reviewed by investigators outside of Texas, I was just remembering being on a Texas Awards Committee one time when it was hard enough to get outside investigators, they don't really care much about Texas, to review this in Texas. If you could tweak that a little bit and say nobody would review any investigators from their own institution, it would make it possible for others in Texas to review.
Let me try to do it this way. I think there's people that I can get outside the state of Texas with the help of this group. If I'm not able to do that, even though we said that we can pay for individuals in their time, then I will explore additional alternatives. I just want to be very careful. That's how Separate does it. They have people outside the state of Texas that they compensate those individuals. I want to kind of follow that model and be very careful with conflict of interest. And I'll come back to this committee if I'm not able to do that. Does that make sense, Carol?
Yep.
All right, very good. Karen?
So
there we go, Karen, and then yes. Okay. All right, Karen.
Hi there. So, as this really is what the field needs now, certainly to expand our children's mental health research. Question that I had is in the document early on, towards the end of the first page, it talks about the focus is going to be on prevention and treatment of childhood mental health disorders. It's in the last paragraph there. And then the next paragraph talks about the focus on improving the mental health system. And then the proposal part talks about improving the mental health system and services. So the question is, some people consider treatment research separate from mental health services research, and some people consider prevention all separate. I just want to make sure that we get enough people applying for all of it. I mean, probably the focus is on improving children's mental health. I mean, I guess that's the bottom line for this research, improving children's mental health.
And I tried, Karen, to, again, be broad, but I have a couple things that were hot button issues for the Texas legislature and specifically called them out that we wouldn't put those dollars in. And that was with these dollars, basic research and pharmaceutical clinical trials.
Oh,
and,
no,
and
yeah.
the ways I left it open, I think preventive type services. I think this is where, part of the conversation is going to be with HHSC related to the strategic plan and the things that they believe that will be part of that conversation. But I just want to be very consistent with the conversations with the legislature, what were their hot button issues that I called those out that we wouldn't fund. But otherwise, I think with some guidance to the committee, with the committee, we can move forward a lot of those other issues you've talked about. Does that make sense, Karen?
Yeah, that does make sense. Do you think if someone were to read this alone, if you look at the first one, the proposal where it's focusing on improving the mental health system and services, should we say related to children? Because otherwise, as if someone took that as standalone, that first sentence, it could be anybody, adults, elderly.
Okay, I can. Why don't you send me that, and then if I need to add a couple of sentences, a little there, and get the approval of this group, I can add a couple of words there if it doesn't change the flavor.
Yeah, it won't change the nature of it.
Yep. Okay. All right, I'm going to go to Dr. Martinez, and then Brittany, I'm going to go to you.
I'm on David's blind side. Just a couple of questions. A couple of comments and a question. Overall, great proposal. I think it would behoove us to have a couple of sentences considering this to our legislature that although this is about researchers, our researchers, especially our young ones who are dedicated to the mental health, improving the mental health system, in fact, is also a leadership opportunity. And so I'm just saying, throw in a few sentences talking about this is where leaders come from. Take a look at all the chairs. How many of them, in fact, are research? And two, it's also an opportunity to diversify our research base. I think that's a huge opportunity for the state of Texas, given our demographics. And then my one question, David, is 5B, and maybe I'm just being dense, but could you elucidate primary mentor must be a member of the institution, Texas Child Mental Health Institute, but does not have work at the same institution as the PI. What exactly does that mean?
It means that Jeff could
mentor your microphone.
I tell you, it means that Jeff Newport could mentor someone in Lubbock, for example, that you don't have to be at the same institution to service.
That would, again, foster additional collaboration across our institutions.
That would be nice to maybe make it more clear for those that are a little dense.
Okay. Brittany, let me go to your hand.
Yeah. Hi. So it's actually Cheryl McCollum Smith. I guess I wanted to ask, and I'm brand new here, but I'm speaking as someone who has a reasonable track record of funding, and a chair. It's a small place, but I've never had NIH funding because I do health systems research, and generally that isn't fundable by NIH. I get funding from SAMHSA and HRSA and other places. And so I was wondering why the emphasis is on NIH funding. I know that bumps everybody up in the rankings and all of that, and it speaks to, I think, several of the other comments, especially going back to Israel and then Karen's comments, that if we're my plan here, and what I did at University of Toledo as chair, was to engage clinicians in health systems research so that they're able to get publications that way. And I have found that it's difficult to get NIH level funding. And in particular with this, it seems like the exclusions are the types of things that generally are NIH funding, and that maybe it's not. Comments from others with much more grant expertise than I have, but that just seems a little bit caterwonky to each other.
So you could add in other institutions if you got funding from that would exclude you. That's going to make the number of applicants smaller as we put more exclusion criteria in it. And
no, I wasn't talking about more exclusions. I was saying that the types of research that you're saying you want to engage with is more health systems research. And in general, I have not gotten funding for my health systems research through NIH. I have gotten that funding through HRSA, SAMHSA. So I guess I was wondering about the emphasis, the goal being on obtaining NIH funding for this.
Yeah, I think any of that kind of federal funding would be part of that goal. And if we need to add that a couple words of other federal
NIH or
funding.
Other federal funding.
Yep.
I think that's correct.
Right. So there is a DOD, here's some, so there's a lot of good agencies that fund it. So if we just insert word level or type funding instead of after NIH, and then the committee will see and approve each project based on its own merit. So we just.
Because I think that even if you're having the external reviewers, if you're saying NIH funding, that sets up a different type of study than perhaps HRSA or a SAMHSA study, you know.
But we have in the proposal, we just have it as extramural funding focused on improving the mental health system. But I can look at other places where it says, calls out NIH. Again, I think it's broad to get federal funding. Yeah. Go ahead.
I think our intention in this program is for the entire panoply of child mental health research, not to be limited to the two major networks. Although we love trauma and depression, this is for the entire panoply of mental health research. That means we would be glad to entertain proposals on autism, proposals on conduct disorder, proposals on ADHD, right? I just want to be clear, child mental health research in the broadest sense is what we want to target.
And I may have said NIH, but I'm looking at this a couple of times where it looks at the purpose and it calls out extramural funding.
Right.
But I'll give it a closer look. But again, the goal isn't that our folks just exclusively get NIH, but get federal extramural funds. Okay. All right, Dr. Trivedi.
Thank you. This is a wonderful program, and I think several places do mention about cross-institution collaboration, where it's nice to have. And I'm wondering if you could take it to the next level where it is almost essential to have, because of the history of TCMHCC. I think it provides a unique opportunity that other places don't have, where you want more cross-institution proposals rather than just individual institutions. So it's a little tough, but worth thinking about.
Okay, no, I appreciate that. Right now, the verbiage is that they're encouraged. I think the committee will work with them related to how much of a bonus that is that you're working with another institution. I think it's we may get there. I think for this first time, being a little bit broad, but taking it into consideration is a way that we can get it moving forward. Alex, then Joe.
Yeah, I just want to get back to what Dr. Nemiroff just mentioned in terms of topic areas. Are there certain topic areas that will not be entertained, such as transgender mental health issues among adolescents?
I think we will fully understand that these dollars are from the Texas legislature, and we will make sure that they are used in accordance to our understanding of how the Texas legislature wants to use these dollars. The consortium as a whole provides mental health services to anybody, and we want to improve mental health services for all eligible, all individuals here in the state of Texas. I think, Alex, it would come down to what they were looking at, and we would need to use the judgment, understanding again that the dollars come from the Texas legislature, and we would need to use them in accordance to what they would like us to use the dollars for. But I think that we've had a lot of support from them related to improving the mental health systems of care for all individuals. Joe, let me go to you.
Just curious how you envision covering any costs for didactic training or experiences in statistics, epidemiology, lab methods, that kind of stuff that, there are a number of institutions already have federally funded programs for that, but others won't. So if there were somebody, for instance, we'll say, just for argument's sake, at RGV, who applies for one of these awards, but clearly is going to benefit from that kind of background training and the didactic components, that would ordinarily be part of most entry-level K awards anyway. Will there be, just to encourage you to think about some sort of accommodation or funding for them to be able to avail themselves of those opportunities from another institution where they might have to pay tuition?
Joe, that's contained within the $50,000 as part of the RCDA. So there are available to use for that.
I see. I thought that was just the money to do the research, but fair pool if that's for other training experiences. Thank you, Charlie.
Okay. All right. I don't see any other hands right now. So I guess what I would like is understand that there may be some wordsmithing to make it clear in the background that this sets up the future leaders of Texas in mental health, making sure it's clear that success after obtaining these dollars isn't just NIH, but could be other federal sources. But I haven't heard anybody say torpedo this and not move it forward. And so if that's an accurate reflection, I would like this group to give us approval to start moving forward. And so I would take a motion.
Move to approve.
I have a second from Karen and Carol. Any further conversation? Hearing none, all in favor of moving this document forward, signify by saying aye.
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 Any opposed, say nay. Has anybody abstained? Okay. Hearing none, I heard unanimous approval from this committee to move this program forward as outlined in this document with some minor changes in words that were discussed here today. Thank you very much. Next, Lachelle, I am going to go to you and Jonathan related to the proposed changes for fiscal year 24-25 biennial participating institutional agreements.
And I'm going to cede to Jonathan. He's been on point this year, so.
Great. We just wanted to provide an update on the participating institution agreements. There will be a fair amount of changes just based on the change in scope of the consortium's work over the last couple of years, but we will be sending those drafts to y'all in the next few weeks. And those will just be drafts because we will also be waiting on LBB approval for our new budget, which will come probably a few weeks later. So our plan is to get final PIAs to everyone around the middle of August. Hopefully August 14th is my deadline that I've set. And that way you guys can move forward with getting those approved, hopefully before the end of the fiscal year. Please also note if these PIAs are not fully executed by the 1st of September, budgets can still be transferred. So funding is not going to be an issue. And we'll just continue to work on those if we need more time after September 1st. That's all I have on that.
All right, any questions? Okay, hearing none. Let's next go to Lachelle, to you to discuss the upcoming TChat Summit.
Great. So we have been busy working to put together an agenda with the HRI's support. Thank you everybody for providing the documentation that we've asked for to try to understand all of your different processes. We have quite a few, almost 250 people that will be attending. And the team has been engaging. I know Dr. Williams has some clinical sessions. We have some operational sessions. The focus will really be on identifying barriers to accessing care, looking at the referral to enrollment pipeline and what things we can standardize and improve from an efficiency perspective, looking at the data and how we can use that to inform care and drive performance. We've got some sessions looking at how we continue to enroll the rest of the districts and schools into services. We've done really, really well in getting the state enrolled. We've just got that last sort of percentage to get on board. And I know a lot of the HRIs have been busy doing that outreach and we're working with the TEA to help us get those final stragglers on board or to identify if they have other services available to them. So I don't have anything more to add than that. We'll be meeting in end of July, and we really look forward to seeing all of your staff there and talking through these really important issues.
All right. Any questions? So it'll be a good opportunity to have, you know, and Lashelle, how many people do we have signed up again?
Just under 250.
So about 250 people across all the institutions gathering together to figure out how do we make TCHAT work better across the state of Texas. You know, I think everyone's doing great work moving it forward. There are different challenges in different parts of the state, different lessons learned, and the goal will be to share that, to steal ideas from each other and look at how we can make some things a little bit more consistent. And so whether there's good ways, you know, we have institutions that have people that have trouble getting people in, and there's some institutions that have trouble moving people out and to get into additional services in their community. We'll be looking at all those different issues and trying to figure out now, after doing this for several years, how do we learn from each other and move it and improve overall TCHAT. With that, Brittany, let me go to you, and then Luanna.
Sorry, it's Cheryl again. Hi. So I am just, this sounds like a great thing. And I've heard San Antonio is really nice. Not been there yet, but I'm just wondering what level of personnel people I should be sending. So I have, for instance, a psychiatrist who is the director of our TCHAT program, but you know, this would be a lot of clinic time. Like, is that the level? Brittany obviously runs everything and coordinates, so she's going. Should I be going? You know, I guess I'm not sure what level of folks you want to have there. More boots on the ground operations, or
Lashelle, you want to take that?
Sure. Yeah, I would say there's a mix. So we do have clinical sessions, people that are providing services to the students, and Dr. Williams is going to be helping facilitate a lot of those. And she will be talking with the CAPS, with therapists, with the people providing care to the children. We've also got the operational groups where it really is people on the ground, the people that are contacting the schools, sending out communications, supporting the collection of information to enroll children into services, arranging the follow-up care when they get discharged from TCHAT. So it kind of spans the spectrum. And at this point, I mean, we've closed registration, but I think if there are anybody that from your institution that hasn't registered that you feel should be there, please reach out to us. As a new person, you might find it very interesting to attend just to understand what those variations are across all of the HRIs. I was going to introduce her later, but Rachel Jew is our newest staff member, and she's our TCHAT project manager. And so she reviewed all of the information that the HRI submitted regarding their TCHAT processes and started summarizing what the variations she was seeing across HRIs. And we do have significant variations. And our hope is to identify what are the things that we can potentially standardize? What are the best practices? What are the things that would help offer a more streamlined process and one where we're not creating inadvertent barriers to care for the families that are trying to use TCHAT? So it's going to be a lot of good discussion. And if you're new, it may be of interest to you.
Thank you.
Luann?
Yeah, the key for us is that if you are an executive committee member and you want to participate, we have to make certain there is not a quorum present. So we will be checking that and have been checking that to assure that there is not. And this is a very operational focused meeting. The way I think about it is if any of you have been recipients of grants where the grant purchases services to be provided to children's mental health at the community level or at the state level. This is really like that, where we are bringing peers together who are doing the work on the ground to gather information from them and identify what things appear to be best practices in terms of engagement and outreach as well as service provision. And so when we gather that information, we will be bringing it to you as the executive committee so that you can learn as well, and we'll categorize things according to the template that we have for the actual grant, the actual meeting of the HRIs. Almost called it a grantee meeting, but and so it's a way for peers to learn, a way for peers to talk about what's working, talk about what challenges they're facing, and then we'll bring that to you. I don't know that we'll have all that data compiled by the August meeting. In fact, I'm pretty sure we won't, but we will definitely bring it to you either in September, October, whenever our team can get that information to you. So I think it will be a wonderful way for us to communicate with you as well about just about how things are going and to celebrate some of the really good things that have happened since we started in 2019.
All right. And again, I realize it's a time commitment. I also realize now that the legislature's put it in $170 million, and we need to make sure that if there's opportunities for us to learn from each other and look at some of these issues that are developing and figure out how to collectively we work together to have a systematic approach to these issues, it's in the best interest of the kids in the state of Texas. And I think that's something the legislature would want us to do. And so it really is a working meeting. It will be getting into the trenches of what is occurring well and what's not occurring well, and figure out how do we really drive those things forward. Danette, I see your hand.
Yes, I just wanted to ask a question. I heard Luann reference the concern about a quorum. And I'm wondering if the quorum, if there's an exception to the quorum for this body, as well as for other open meetings of government for training purposes, because there are exceptions for which a quorum is not a concern in terms of the deliberation of the body by statute. So I throw that in, maybe you don't know the answer now, but I'm not sure for purpose of an operational summit such as being described, if there should really be a concern for the quorum.
I'll look into it. I'm always concerned about a quorum, but maybe I could be less concerned in this case, but I'll look into it. But we should assume that concern remains absent further information.
I don't think we're going to be hitting quorum. I think we need to keep our eye on that ball, but I don't think our institutions are sending both of their executive committee members there and in any institution. And then the variety of other partners, I don't think that they'll have individuals there. So again, we'll watch that closely. We want to make sure we're in compliance with the Open Meetings Act. But we also encourage our institutions to send people that are really working on the TChat initiative that have on the grounds truth related to the challenges of getting kids in and getting kids linked to services in their community. And again, we're going to work and together to figure out how do we adjust things to move things forward. And would welcome our executive committee members. If you want to attend, you're welcome, but just let us know so we can continue to watch the quorum issue. Thank you, Danette. Steve?
Yeah, is there a website up for the actual schedule and everything? I don't think I've seen one at this point. I was just looking on our general TChat website. I didn't see any mention of it, but maybe I'm looking in the wrong place.
There was a website with the registration. It is internal. This is not something that external people can attend. It's internal only, but I can make sure you get that, Dr. Plitzka.
All right, very good.
Okay, very good. Let's go. Laurel Williams, Dr. Williams couldn't be here today, but I would think we have Edith and Jennifer that are going to fill in for her. And again, Edith, it's great to have you here. I know you've been working on this for quite a while now. And so let us hear from you related to where we currently are related to the cost.
Absolutely. Let me share my screen. Can you see my screen?
We can.
Perfect. We wanted to give a quick update on the call volume for CPN. From June 2021 through June 2022, we've received about 8,346 consults. Moving to this year, July 2022 to June 2023, we received 11,932 consults, with our highest month yet in May of this year of 1,317 consults.
Very good.
Direct consultations, we've received 206 since the beginning of the pilot. Currently, 9 teams are offering direct consults, and we are currently working with all teams to be able to offer direct consults across the state to all providers by this fall. We just completed our Project Echo Spring series, offering 6 sessions with the attendance of 928 learners for spring. The Project Echo work group has already met and selected 6 topics for the fall session, and it will begin September 18th and complete November 27th. So some updates for trait CPN roadmap. Medication is going to be deployed in 3 phases. First phase is in development, and a release date is scheduled for September of this year. Phase 2 and 3 are still in final design, and our PCP portal is currently in the focus group phase. We have a couple of features that are still in defining requirements phase, which are multiple consultation on a single call, call form part 1 improvements, call form part 2 improvements, direct consults form, 30-minute callback improvements, and consult summary printable version, all still in defining requirements. WellNeti, our resource database system, is currently also undergoing a couple improvements with the help of Lachelle and HRI work group. Some of the areas that they're improving are searchability for information, adding new resources, editing existing resources and tracking changes, ensuring quality of resources, extracting resources of distribution to provider, and reporting. Timeline for this is 2 to 3 months, with phase 1 being 2 months, phase 2 in a month after the first phase. And I believe that is all for CPN. I will move it over to Jen for TChat.
All right, thanks, Edith. So taking a look at our first slide, this shows again the growth of TChat. The blue line is the 21-22 school year, and then the orange is our last school year. The numbers at the bottom are actually through the end of May. So we've had 40,854 students that have been referred, and then 23,497 that have been served, with a total of 89,204 sessions. And this data again is through the end of May.
Yeah, that's a impressive number, 89,000 sessions. And so I just don't want to gloss over that too quickly. Your teams have provided 89,000 sessions to students across the state of Texas. So sorry for the interruption, Jennifer. But that is, I've seen that before, but it is, significant. Another thing as we approach this TChat Summit, that number of kids referred versus number of students served, is going to be one of the issues that's discussed. And how do we look at, some of the barriers of students that get referred from actually getting into service, whether it's parental consent or a variety of other barriers that they face before they can actually get served. But that's why this data is very important. So thank you, Jennifer.
I think it's a great number. One of the things that we piloted in a very small pilot earlier this year, we had an HRI that was developing a wait list of students that they just weren't able to serve for staffing issues, kind of a variety of things, and they were starting to develop a wait list. And so we worked with 2 amazing HRIs who jumped in and were very excited to work with us. We worked with Trait, and we're able to work out a system where we were able to cross-refer. So the 2 partnering HRIs were able to take the referrals that came in and actually see those families. So we met with the HRIs, we worked out systems, great scripts to work with the families to offer them the choice of whether they'd like to stay or whether they'd be open to being seen. We worked with the CPAN team to develop a system so if referrals were needed in the community, we could work with them to get the families referrals so they wouldn't have to be moving around. We can make it a very streamlined system for the family. So on their end, they were receiving care, they were receiving access, and then if they needed further referrals, it was just a very smooth process on their side. So it was a great project working with a lot of different partners to be able to make sure that those kiddos were able to receive care, and 29 referrals were shared out amongst the other 2 HRIs.
Good.
Next slide. And for our trait initiatives, we've got some really big projects. We have the medication tracking project, which I know has been in the process for a while. There's been a lot of great feedback from HRIs and various stakeholders to really refine this. So we begun testing that last week, actually, and we're hoping to complete testing this week. We've asked all the HRIs to identify folks and make sure we're getting really good feedback. And then depending on the feedback, we should be able to release that before in the regular portal before the school year starts. We also have the school portal metrics that'll be going live, and that'll be going live by the end of July. So the districts will actually be able to see aggregate data around the number of referrals that they've made, kiddos seen, things like that. And then the automated CIS, so that the parents will automatically receive the link to complete the CIS, is in its final design. We've also had some feedback that it would be useful for a message to pop up on referral screens so that counselors are aware that they're, if this is a student that's at a higher level and maybe not the best fit to utilize their crisis protocols. So that's in defining requirements. And then we have a couple of other smaller projects. The RCADS assessment is testing in the sandbox and should be released. And then using email as a multi-factor authentication was another item that came up in some of our meetings with various school districts. And so that's actually still in the defining requirements phase. And so those are our TChat updates. So with that, any questions for the Kosh?
Can you just spell TRITE? What it stands for?
Which I'm sorry.
Anybody know what's TR?
So it's just the name of the
It's the
company.
name of the company. Trade is a startup company.
Oh.
It's a vendor. It's a vendor that
Our
they
data
contract
management
with.
system.
All right. Any other questions? So it's been interesting for us over the last month. We've been talking to every HRI, and Jennifer, you showed some of this. That there is some decrease in volume, although some of our institutions are saying they're still going, full tilt. That it hasn't slowed down as much as they thought during the summer, and so it'll be interesting to see kind of over the next several months as we start the next year, kind of what the new starting point will be. So again, thanks everyone for all that hard work. Any other questions related to the Kosh? Hearing none, Dr. Wakefield, Sarah, I'm going to go to you.
Yes, hi. Jen, did we decide who's running the slides? It's EC committee.
I'm grabbing them right now.
Okay, great. We're really excited to talk about all that's been happening with the CPAN expansion into Peri-PAN. I see it's up. Thank you, Lachelle. There we go. Okay. So wanted to show just our latest metrics related to Peri-PAN and the pilot, just as a reminder to those of you on the committee and those who might be new to the committee. This was an expansion authorized under the American Rescue Plan Act, or utilization of the American Rescue Plan Act out of the 21 legislative session in the Texas legislature to expand and enhance CPAN to provide services to those women who are pregnant and up to 1 year postpartum, to not just benefit those moms, but also to benefit the children that they were having, and to try to prevent, be a preventative measure for children's mental health distress in the future. So we launched this last August, went live. Of course, there were lots of planning that happened prior to that, but went live with our line in 4 pilot sites: UT Southwestern, Baylor, Baylor, Texas Tech, University Health Sciences Center, and Dell in Austin. So this is, and we've been having a lot of collaborative discussions around that. And here is where we are so far. So when we look at the providers, this is all providers for CPAN and PeriPAN. And that's really important because we immediately offered PeriPAN services to our family medicine docs and our pediatricians and other advanced practice providers who are already enrolled in CPAN, and then extended the PeriPAN services as well to obstetric providers in these 4 pilot areas. When we look, we've had 300 completed consults, 221 patients served. One of the metrics that we look at is the response rate. So response within 30 minutes to the clinician calling for the consult. We have 100% response rate within 30 minutes, but our median response time is less than 6 minutes. So we're really trying to be as active as possible and responsive. We know that our obstetric clinicians, all of our clinicians are very, very busy, and we want to serve them as timely as possible in their mission to provide the very best healthcare to their pregnant postpartum moms. Next slide. So this is our overall data. There's a lot of data on this slide. This is a screenshot capture from the trait system. So one of the things that we did was spent a lot of time prior to launching the line in building out trait to that same vendor that we're utilizing for CPAN, so that we can continue to capture these things from the very, very beginning in PeriPAN and be able to show you what we're doing here. We look at our monthly consult volume is continuing to rise, maybe not as drastically as we would like to see, but we know that this is pretty par for the course when you're just launching these lines. And we'll talk about some initiatives that we are planning to increase our engagement and enrollment and hopefully our call volume. This middle center section, I think is really important that we look at called only once versus called multiple times. And we're seeing that called multiple times number go up, which is exciting because it shows a value to our line that people are finding and wanting to call again. But we're still going up also in our called only once. So we're continuing to engage even new clinicians or clinicians who haven't called before. And so I want to talk to the teams about how much I appreciate that those efforts at continuous engagement so that we can increase everyone's knowledge about what service we can provide here. We in clinic staff roles, the majority of who is calling in are physicians. Then down here in the purpose of contact, so there's the calling about specific patients. That's over 77% are calling about specific patients. There may be people calling also for enrollment. There may be people calling for just general guidance, asking what would you do in this certain situation, or I have several patients under this. And so not linking that to a direct patient care episode, but more of a general practice guidance discussion. About 61% are requesting referrals to the community, and we can talk about what those referrals look like in just a second. About 50%, 49.33 are medication related. So calling to say, hey, this woman is on this medication during pregnancy. Is this safe? What should I do next? She's still symptomatic or she's no longer symptomatic, and having those discussions in real time so we can help support mother's mental health. And then this is 24% requesting the callback. And we're seeing about 3% calling in an emergency, saying, I'm really concerned about this mom. What do I do next? Either danger to baby, danger to mom. And so providing some guidance. Again, we're not an emergency crisis line, but we can provide guidance and overall general response to what is evidence-based in an emergency and can help locate some resources, especially for after that emergency has subsided. In change recommendations, we are seeing that 88 consults have requested out of that 148. We have recommended a change in medication. So providing that value to the clinician who's calling in saying, hey, I'm not sure what to do next. And there is a medication change recommended. And I can tell you when I've answered these phone calls, it is often mother's on this dose of medicine. She's continuing to be symptomatic. Should we change the medicine? Should we increase the dose? What is the safest thing to do in this instance if she's pregnant or postpartum? And so that's a clinical discussion, case to case, with those specific case details, but it helps inform practices going forward for other moms. And that's really the goal of these access projects or access lines, are to increase the capacity of the frontline clinician who's calling in. So not just the importance of that specific case discussion, that information and knowledge permeates other clinical cases in the future as well. We look at the referral information. There's 141 with recommended referrals here, mostly about 41.67% to a local therapist, recommending, utilizing our PeriPan teams to find a local therapist that has that takes the woman's insurance and can respond in a timely manner without a significant wait list. This is the difference in just offering in a clinician's office a list of potential people who might be able to see that woman. Often we know that at least in practice, if you do this kind of work, that the woman comes back and says, well, I called 3 people, nobody could see me, so I gave up. The goal here is to really be have an updated list. This is, you heard about the Wellnity changes that are coming to really help us know about this statewide, be able to look in a certain area of the state and say, this is the wait list for this therapist, this is the insurance that they take, so that we can apply that in a timely manner to really get access to care or improve access to care for our pregnant and postpartum moms who've identified that they would like some intervention. Local adult psychiatrists, we see this is about 20%. We have launched direct consults as well with PeriPan. And so we're really excited about offering that service from the very beginning as a part of PeriPan, and trying to minimize the number of women that we're referring out to for additional specialty care that often is non-existent. That the goal of PeriPan is really to, when needed, see that woman in a direct consult capacity, identify, clarify diagnoses, and then recommended next steps in treatment that we can share with her treating clinician and improve care as quickly as possible. Any questions about this slide before I go on? Dr. Potawitz?
How many OB-GYNs are now part of the network? Of the consults, do they come from primarily pediatricians or primary care, or how many came from OB-GYNs?
Oh, that's a great question. I don't have that data right here on this slide and in the breakdown of where the consults came from, but we can get you that number. We have that data. It's just not on part of this slide. All right, I'll ask Jen to see if she can pull up on Trait and see that number in the analytics, and then see if we can get that to you before the end of the presentation. If not, we can send that over to you. Okay, next slide. So PeriPan enrollment, our teams have been very busy, over 40, this is just obstetrician data. So we're just looking at the enrolled OBs. We wanted to have a specific metric for PeriPan. And even though we know we kind of automatically enrolled the pediatricians and family medicine docs, but those were already being captured in our CPAN metrics. So this is just obstetrician, OB-GYN, MD data. We're also enrolling nurse midwives, we're enrolling psychiatrists, we're enrolling others, but this data right here is the percentage of the obstetricians in these 4 pilot regions that are enrolled. And in some of those regions, that is a very, very large number. Like we think about Dallas has a very, very large number of obstetricians in the Dallas area. And some regions, like in the Lubbock and Panhandle region, that's a very small number. But when we look at the enrollment over time, our teams are doing a great job of getting out there and finding those OBs presenting to their offices, despite how very, very busy our obstetrician colleagues are. And so you can see this increase in enrollment over time since we launched in August. Next slide. I wanted to talk a little bit about a project that we are launching to increase and improve the education across our residency programs in Texas. We just as an overview, there's a national curriculum of reproductive psychiatry that is recommended to improve resident or psychiatrist knowledge and in perinatal reproductive psychiatry. We have identified the what are they called? The pieces of that curriculum that are specific to perinatal psychiatry. And so not the pieces related, which are really everything not related to menopause, but the pieces that are relevant to perinatal psychiatry, and developed a curriculum from that, a subset curriculum from the National Curriculum of Reproductive Psychiatry. And then our idea is that because PeriPan, we've really focused on improving education and building out an educational platform from the very, very beginning of this line because of lessons that we have learned from the development and rollout of CPAN. So I'm going to talk about multiple of the educational initiatives, but one of them is to really provide additional education to our residency programs across Texas. And I'll show you why in just a second. Next slide. So on this slide, you can see that when we surveyed our residency programs across Texas, the child psychiatry fellowships, adult and rural residency programs, we received responses. We said, would you benefit, or would you feel like you benefited, had time for, would like to engage in perinatal psychiatry curriculum? There was a study done a few years ago from outside of the state of Texas, and I don't know how many residency programs within Texas were surveyed for that study. But what I know is that the average across the country is 6 hours or less of perinatal or reproductive psychiatry education, despite more than 50% of the population being served in psychiatry being women, and also having many, many different impacts on mood with the hormonal changes in women across their lifespan. And so there is a national recommendation to improve this education in perinatal and reproductive psychiatry within psychiatry residency programs. And that the average is less than 6 hours. I think I might have already said that. So we surveyed internally or across the state of Texas, the information or the education that our programs are getting in reproductive and perinatal psychiatry. And we don't have responses from 100%. So I want to say that that's important when we look at these bottom numbers. But most everyone said, yes, we'd really like to engage in this. This would be administered from our PeriPan team, utilizing that national curriculum of reproductive psychiatry that's pertinent to perinatal. And when we look, there are one program, and there's very limited, even across Texas, the education being provided in perinatal psychiatry to our residents. We do have some women's mental health tracks. We do have some hours being provided from a few residency programs, but this would provide a really organized curriculum across a continuum that is facilitated by PeriPan to residency programs. We know that there's no board certification in perinatal psychiatry or reproductive psychiatry, and so it's really hard to know or to tell people what is the standard education here that is recommended. So there are some fellowships across the country, and with the National Curriculum of Reproductive Psychiatry, we do have some sort of a standard now. We'd like to offer that to residency programs at no cost and build it into their schedule. So we're working with them to do that right now. Any questions about that? Yes, Alan. Well, before if I can go to the next slide real fast, I will say, and then we'll take some questions. So these are just when we surveyed the various programs, we had an area, not just for, response for yes, no kinds of responses, but for some narrative responses too. And these are some narrative responses we received from the residency programs across the state. And so we're really excited to partner with residency programs to provide this. All right, Dr. Potter-Wiltz.
They're a wonderful program. I'm so glad to have this because my residency, I actually had some time to actually take a look at this, and that was, I don't know, 100 years ago. So I'm sure we've come further in our understanding, which brings me to my next question, is that we probably have some faculty who would be interested in this. And we also have a very large advanced practice cohort. And I think that they may be interested in this as well. So we are going to participate in I have the training director with me right now, Dr. DeMoss. We will participate in this curriculum, but is there a way for us to do staff development off of this? Can we record them? Can we do other things? To get it to the level?
Yeah. Our goal here is to improve the education about this. And, I think so in whatever way we can do that. And if this is quality improvement, an iterative process, like building anything is. And so any recommendations that you have, we are not going to limit who can participate in these sessions. Now, we do want it to be a good learning environment for everybody. And so we may need to have additional sessions with additional focus of who is attending so that we can really have, appropriate discussion per those levels. There may be differences in the needs of a faculty versus an intern and what they need for, this education and in the discussion that develops after that. But on the flip side, it may be very helpful for everybody to hear each other's different levels of questions and facilitate that bigger discussion. So I'm happy to see whatever way that develops. As we've rolled out education, we have seen that usually the engagement is quite small at the beginning, and then it gets larger and larger and larger. So I imagine a scenario where we can have all learners, everyone together in the initial kind of phases. And then if we get more and more and more participants, it may behoove us to not limit, but more organize it where we have learners either in a cross-collaborative and interdisciplinary kind of framework, or residents altogether, or faculty altogether, APPs altogether, and we can learn that together as we go.
Nice. Good work.
Thank you. Dr. Taminga? You're muted.
I just wanted to remind Alan that we're close neighbors, Alan, and we have a very active program in Perry Pan. So you're welcome to call anytime, and we can set something up that meets your needs.
Thank you.
And I will say, in addition to that, we have some other slides on it, but we have a robust education and we have monthly webinars that happen, every single month. And we have an Echo series that I have it's just been the recipient of such kindness and collaboration across the pilot sites for the development of this program. And we have presenters from every single pilot site facilitating this education as well. And those webinars are open to anyone across the state. And so you can get that link right now, and your faculty, residents, APPs can start participating in that curriculum, which is not exactly the NCRP curriculum right now. So we can send you over that link. Jen, I know she's on this call, so I just keep saying to Jen, the angel in the sky, but Jen, if you'll send that link and make sure Dr. Potter-Wiltz has it, I would appreciate that, to the webinars.
Dr. Trivedi?
This is wonderful, sir, Dr. Wakefield. I think as you were describing about engaging residents and fellows and even qualified psychiatrists, I was thinking our surgical colleagues or people who develop new devices or interventions or rad-onc people, they create these 2-3 day training seminars when there's new surgical procedure or new intervention, and people go there, and that jumpstarts them in that process. Maybe we're thinking about for people for the curriculum you're creating.
I think that's a great idea. I'm putting this out there for Lachelle. We're developing a CPAN summit where we'll also talk about PeriPan expansion. And I know there's lots more discussion that we need to have about that and very focused things we need to do at the CPAN summit, but an idea to maybe have an add-on training session in person for perinatal psychiatry too as a part of that. I'm just putting that out in the ether and we can talk about it at some point.
We'll add it to the list and talk to you about it later.
Okay. Thanks. It looks like Jen Erdigy put the link to the PeriPan webinar in the chat. I'm not sure if that is legal because we're supposed to put everything out in the, not put things in the chat, but I will say that it's there for the panelists and that we're happy to have it included in the minutes. And for anyone, it really is, the webinar is open to family medicine docs, pediatricians, APPs, OBs across the state of Texas. And and psychiatrists, residents, our goal is to improve the education around perinatal psychiatry. So if you think that could be helpful to you, we want you to attend. So we're happy for anyone and everyone to have that webinar link.
All
Next
right,
slide.
very good.
Yeah, Dr. Leakey, I'm sorry, we're not done.
Okay,
Yes. So we are almost done. We want to talk about PeriPan expansion. We're really excited to be able to expand PeriPan across the state with the reappropriation of those ARPA funds. And now, I guess, conclusion of this pilot that we did over the first 2 years that, in my opinion, and with the opinion of some other folks that we've engaged outside of Texas to help us, because they've done this in many other states, that we've been wildly successful. And we're really appreciative to all of the pilot sites that helped us implement this. And now we want to take it statewide. And so we've been talking a lot about what that means and what that will look like for the state of Texas. And so I know everyone's been thinking through their budgets and thinking if they would have the expertise and the time to engage in this. And so I wanted to have a conversation here and present some things that we have been thinking at the COSH level and with PeriPan. So when we looked at what does it take to take a program like PeriPan statewide? We did a lot of the work that we did prior to the consortium ever existing when we were looking at CPAN and preparing and planning for that. So we looked at other states and how they were staffed for perinatal psychiatry, for a perinatal access project, and based it on the births annually in Texas. There are a lot more births annually in Texas than there are in some of the other states that have a perinatal access project. So we did some simple math and multiplied based on those numbers and came to the appropriate number of reproductive psychiatrists would be about 6 to 7, depending on something else that I'll talk to you guys about in a minute. But 6 at the least, and maybe 7 would be an appropriate number. What is the required expertise? I had just talked about that we don't really have, because we don't have a board certification or an RRC for perinatal psychiatry or reproductive psychiatry. We don't have that information like we have for child psychiatry. A child psychiatrist is someone who's done a fellowship in child psychiatry and is board eligible in that. So really working with our the folks that we're working with nationally and saying, what does it mean to be a qualified reproductive or perinatal psychiatrist to staff a line like a perinatal psychiatry access line? And so we talked about 2 different components are really important. One is the knowledge, and one is more of a skill set. And the knowledge base being board eligibility or board certification in general psychiatry, plus a women's mental health fellowship training, or because we know those are very limited across the nation. And so the expectation is not that everyone has done a women's mental health fellowship training, but the expectation is that you have a real live experience in treating women in the perinatal period over a longitudinal time. Because there are nuances and really important things to know that are different than what many of our books and our test questions say. And so it's not something that you can just read about and know what the standards of care are, because many of our books and test questions are not up to date with the standards of care in perinatal psychiatry. And then the second component is really the consultation skill set, the ability, and so there's a recommendation to have someone with a consult liaison psychiatry fellowship training should have that skill set. But not everybody who does this needs a CL background. But everyone who does this does need an effective skill set for providing quick, concise, collaborative guidance for clinical care. This is not, tell them everything that you might do in every single instance, because it's very overwhelming. We're not in an access project. We're not trying to train other people to become perinatal reproductive psychiatrists. We're just trying to increase their capacity in that frontline clinical care. And so each nugget that they get for that particular patient encounter increases their capacity overall. And so we don't want to overwhelm people. We want to empower them and support them in their clinical care. This is not a fully clinical job. It's not something just for, it's not the same as providing one-on-one patient care by any means, although we do have the direct consult piece built into PeriPan. There are responsibilities for outreach, education, in addition to providing the consultations, and also creating and presenting our ECHO and webinar sessions. We had just talked about how collaborative of a process that has been, and people have contributed over time. And engaging in implementation assistance with practices. So helping the PeriPan team really engage that practice, calling people, calling your other colleagues about these services and how you can serve them to increase the utilization. Anybody, I want to pause here for a second to see if there are questions about this. All right, next slide. And so we talked about the 6 to 7 psychiatrists, 6 program coordinators, FTE. This could be a shared position and would recommend it being a shared position with CPAN coordination and direction to really integrate these programs and utilize, we want to expand what CPAN is doing, not replicate it. 12 FTE resource and referral specialists. So at least 1 FTE of a time dedicated to being able to look at resources and referrals for perinatal mental health support. It should function as a cohesive whole at the state level, where we are able to cover for each other, just like CPAN, and including that direct consult piece, participate in statewide leadership, one-on-one and role-specific meetings, improve utilization, outreach and education, like we talked about, and then engagement and implementation assistance with practices. And I think that's our last slide. We wanted to talk, yep. So the implementation piece with practices, we're really looking at, we can stop sharing, yeah. Looking at a model coming out of Massachusetts where that's been evidence-based to increase utilization in the access line by utilizing some of the newly released AIM bundles for obstetricians and obstetric care and mental health to help practices implement those and then teach them when it would be a very helpful time to call PeriPan. So we're looking at integrating all of that right at the outset of taking PeriPan statewide. And that's all I have.
Okay, good. Well, thank you, Sarah. Any other questions? Nope, it's exciting to see PeriPan being rolled out. We'll talk about it a little bit more in the budget and the dollars that have been put in for the statewide rollout. But we need to take a break. And so we'll take a break. I think we'll start at 12:45. So that gives everyone it's about 25 minutes for lunch for this group. We have lunches, box lunches further down on this floor, and we'll start precisely at 12:45. Sarah, do you have a question?
I just wanted to tell Alan, it looks like 120 of the consults were from OBs, 60 from pediatricians, 80 from family medicine, and then some others from different mental health clinicians and community centers. So still our primary driver is OBs, followed by family medicine, followed by pediatrics.
Amazing. Good work.
Thanks.
All right. See everyone at 12:45. Thanks.
have to get to it pretty quick.
We are regathering here. I think we'll be ready in about another minute, and then we'll go ahead and get started. Just need to make sure I count heads and that we have a quorum again. All right. It's going to let a couple of people take a seat, and then we'll begin. So we have two things left to do on the agenda today. We're going to go through the report we give to the governor's office on the TChat rollout. And then we're going to jump into the budget and need to get a preliminary approval for the budget, which is based on the conversations we've had with each institution over the last month. But before we do that, why don't we jump into the TChat governor's report? And again, I want to thank everyone for all the hard work to really build out TChat over the last several months as we continue to work towards implementation statewide.
I'm just going to bring up the map to start, and then I'll jump to the governor's report. But I just looked at this last month, and it just really impacted me how far we've come in terms of rolling out services across the state. I remember when the shaded areas, which represent where we have active services across Texas, had far more gaps than what we're seeing right now. So I just want to commend all of the HRIs and the hard work that they've put in to enroll all of our schools across Texas. The governor's report is on our team site for those that want to review it internally. This is sent out once a month. We're always a month behind in terms of data gathering and analysis. So this is as of the end of May. We're starting to review the June data right now. Colors look a little bit different on the screen, but what looks like blue here is green on my screen. That's where we have live services right now. You'll notice a couple of changes from the last time that I reported this out. First one being that we've pulled out those schools that have declined because they have existing mental health services, or they've indicated that they have existing mental health services or another way to provide those services. So we have black has declined and this darker gray as declined, but we have existing mental health services. I've also put in a purple, which is unresponsive to outreach. This is the biggest barrier that we have in enrolling districts into TChat. We've got schools that are outreaching, or the HRIs that are outreaching to the districts have communicated on a number of occasions, but are not getting a response from that school. Now, we do implement strategies to try to overcome this, including engaging the TEA, and the TEA meets with their ESCs. I provide an ESC level report that they can then use to identify, here are the districts where we're live, or here are the ones where we're not getting a response. So they can hopefully help us engage those districts. Right now, we're about 60, I think it was 63% enrolled. There is a student population covered, which is different from last time. This one has, again, the declined because of existing mental health services. And so overall, we've got 35% of the state that we're expecting or hoping to get a response as to whether or not they would like to participate in TChat services. On the graphic here at the very bottom, you'll notice that I've got the total population for the state. This is all of the students who are eligible through their schools for TChat, but then I have a darker number that's a little bit less than that. That darker number excludes those schools that have declined or inactive. And so this is the remainder of what we have left to enroll. The other thing that we've added to the report is where the HRIs have given us data on when they plan to implement or roll out TChat with schools. We now have this graphic that shows when they're expecting to do that. As you can see, we've got a big bump that's expecting to happen in August. That makes sense. That's when all those schools are just starting up. And so they'll be onboarding all of those school districts in August. And then when we get our report in September, that will reflect a huge increase in the number of schools that are active with TChat.
Yeah, a big shout out to UT Southwestern's team. That's a large number of schools that they're bringing on this summer. So Isham and Carol, that's a lot of work. So thank you.
This just shows for each ESC region what that rollout looks like in terms of districts that are active, and then what's left and what proportion we're having problems engaging. This shows the growth over time of both the student population and the number of schools covered by TChat. And then finally, we have a slide that talks through the reasons that have been provided for districts declining TChat services. Majority of those have been that existing mental health support, and that's why we pulled that out into that separate decline category. Any questions? All right, thank you.
Got one.
Go ahead, Steve.
Sorry.
We've had a couple of districts that have, well, what they've done is, it's not that they've said no, but they've come back to us with, and this is only in 2 districts, so I don't want to make it too big a deal out of it. Basically with conditions that weren't agreeable. Like both of them, it was a theme of, we'll send you the referral and you take care of it, and you have to guarantee us that you'll see them after outside school hours. And so we had to say to both these folks, well, no, we can't guarantee that. And plus, we want more of a collaborative relationship with you. And that's kind of where it left it. I think we're going to name those, we're going to list those as decliners. And they're not declining because they already have mental health services, but they're declining because they just kind of don't agree with our model, or see us simply as a referral source. We'll put you on the list with everybody else we refer to. And again, it's only happened with 2 districts, but it kind of was taken a bit aback by all of that. But I don't know if anyone else has had experiences of that sort.
Hey, Steve, can I share a thought on that? I think that there are many districts that have that concern. In fact, TEA last year had to rescind a rule, actually it was 2 years ago, where they were going to penalize schools for sending children to telehealth visits during school hours and not give them credit when they were counting for attendance. And attendance is a really big deal for school funding, as folks know. So it actually might be helpful. I don't know if we have the TA representative on today, but like if Julie's around, or to connect with Julie, because there may be just misinformation. I mean, I'm sure across 1,200 school districts, some of them did not note the memo from TEA when they changed that. So it may be that that's their concern. I don't know, you have more robust conversations, but I do know that many schools are very concerned about that. And it's been an issue for some.
Although in the case of these two districts, they also were unwilling to do on-campus services. I said, no way, we're not going to take the kid out of class and put him somewhere where he can do on-campus services. So I don't think the attendance rule shouldn't be an issue. So it was more they were saying, it's fine for us to refer to you, but we don't want to be involved in any way. It was more the message not me personally, but our outreach people got.
Yeah, it'll still be good to talk to Julie, I think, because I think,
Right.
I mean, because it's super complicated.
Very good. Carol? Up, you're muted, my friend.
Sorry. I just wanted to say a bit defensively that we are working on decreasing those numbers, and those are obviously last month's numbers. So this month we had our salmon colored bar down to 335, and the rest of those were converted to black and green, which we're trying to do. And by the middle of September, once everybody comes back to school, we'll probably be in line with all the other centers. So we won't do that again. Thanks, David.
No, you guys are doing great work. And again, it's complex. It's a big metropolitan area, but there's a lot of, the reason we have that second chart there is to show how many of those are coming online with due dates. And the vast majority of those are UT Southwestern coming on. And so, the other thing that we've heard in the conversations we've had over the last month is a lot of large ISDs are, you're in the midst of activating their MOU. And so I expect, in a couple months that 3.2 million is going to be quite a bit higher as those large ISDs get added in.
And we have a lot of our schools who have already set up programs, especially the larger school districts. They've already set up programs and they don't understand exactly what the contribution of TCHAT would be to the programs that they have. So they're being just a little bit more conservative. And the places that they say, where they tell us no, we say no just means no for today. And you can give us a call anytime and switch that out to a yes. So that's really helped people come to a decision a little bit more.
No, that's good. I think that's right. That we're here for the schools that want to implement it. We're here to implement it. And if some of them need to take a little bit more time, we'll keep coming back and making sure that offer is available. And Steve, I don't think you're alone in that situation. As we've had a conversation, there's a couple of schools that they want a different model and something a little bit different, and we'll keep listening to them, but we also want to make sure that we have a quality program that we can stand behind. And so, that'll be part of the discussion at the summit coming up of, when schools want a different model, either because they don't want to have it in their school or make classes available, time available, or some of the other issues that have been brought up, trying to think through a systematic approach to that across the consortium.
And we're sympathetic to the problem the kids, if they miss school, it's a big deal. We do offer after hours every night. We have a couple of our therapists stay late to see people who just can't, it's not in their interest to be seen during the day. Yeah. The problem is we can't guarantee that to everybody, because then we'd have therapists that are only working, 15 hours a week, because that's as many hours as there are between 3 and 8 o'clock. You can't see a 10-year-old at 9 o'clock at night.
Yeah. All right. Any other comments? Hearing none. Thank you, Lachelle. And Jonathan, let's jump over to you for the big item of the day and talk about the budget. And for those of you that haven't been in these discussions, maybe a little bit of background. We, over the last month, have had independent conversations with each of the HRIs to make sure we understand what their current needs are and compare that to where we were back in September when we talked to the legislature and worked to get the dollars put into the base budget. As you can imagine, there's been some changes over that time period. There's some programs where people have figured out where they can be more efficient. And some of those costs have come down. And there are some places where they say there's additional opportunity. And we've been trying to flex dollars to get them into those additional opportunities. And so with that, there's some changes between what we gave the legislature a year ago, but we're still within the budget and still have the ability to move those initiatives forward with the adjustments. What we're going to be looking for today is I need a preliminary approval from this executive committee to move forward on this budget with the nuance that you give us the flexibility to make some adjustments as needed to make sure that if there's a gap or hole that we figure out how to fix it. And so those are minor adjustments, not a major change. And that's what you've done for us in the past in order for us to make sure we get the dollars out as effectively as we can. And so again, appreciate the support, but we'd like to get a preliminary approval today and get the dollars into your institutions. And one of the things that Jonathan's having to balance is not only, institution by institution and programs, within the institution, but since we have two flavors of money, one of the things that he's having to adjust is, what do we pay for with ARPA? What do we pay for with GR? If we're a little low on GR, are there some things that we can pay for with ARPA? And what does the statutory authority say that we use the GR dollars for? And so it takes a little time to make sure all those nuances are addressed, but he's been doing a great job making sure they're identified and then we move them forward. And so with that, Jonathan, I'm going to turn it over to you.
Great. Yeah, and just to add a little bit more to that, there are about maybe a handful of HRIs that still are submitting some tweaks after conversations that we've had with all of you. So these numbers will change a little bit, but not expecting major changes there. So we'll start with just an overall comparison of what we asked for. So the second column here was the amount that we asked for based on what we thought we needed when we were evaluating this back in September. And so you can see the column next to that is the request that came in this summer for what folks have actually decided they needed. And then the last column is just the difference between what we originally thought back in September and kind of what things are shaping up to look like based on a reevaluation this summer. And so you can see the biggest decrease in the amount of funding that we think we need is the $7 million for CPAN, which also includes PeriPan. And here folks are realizing that it's taking less staff to meet the demand. I think there was also some, for PeriPan, there were only 4 pilot HRIs that were operating within the pilot. And so for the other HRIs trying to kind of guess what they think they thought they would need, had some time to reevaluate what that is going to take. And so you can see that that decrease has kind of been made up by some of these other initiatives. So we've seen an increase in the other workforce development initiatives that are being proposed of about 2.3 million. There's been some increases that Kosh is expecting, primarily around contracts with Trait and some other technology needs that have been identified. And then again, at the bottom, you can see an increase in what folks think they need for TChat. And so the difference here is pretty minor between what we asked for and what things are kind of totaling up to be. Again, these will change a little bit, especially as we kind of allocate funding towards ARPA versus GR. You can see the note at the bottom there. These figures in this middle column include what we anticipate to be going towards the indirect rate for ARPA projects, which is about, at this point, 6.8 million. So again, as we kind of adjust those, which initiatives are funded by which funding source, that could change a little bit.
And I guess the one point that we had some discussion on is, yes, it's just a little bit higher. How do you address that? The reason we're able to address that is because of ARPA and carry forward, and it's actually a little bit more than what we anticipated last year. And so there are the dollars there, and there's some additional dollars. And so as we go through this year, as we see opportunities, especially with TChat, to continue to roll it out in in a couple workforce areas, if there's some opportunities, we're going to continue to have those conversations to try to maximize the expenditure of those dollars. Israel, Dr. Liberson?
So
maybe question to Jonathan. Jonathan, can we have that one? Since within institutions, the GR dollars and ARPA dollars go through different pathways, and one is funded through SRS, and one through that. Can we have a breakdown between for each category, whether which portion is funded by ARPA versus which portion is funded by GR?
So I don't have that in this presentation because it's still being kind
Yeah,
of
yeah.
formulated, but before we finalize anything with HRIs as far as which bucket of money that's coming from, you'll have a chance to review kind of what that total looks like and which funding source has been applied, and if there are any concerns that we can.
Well, that's what I
address
was
those
asking.
there.
Thank you.
Yep. And that'll be part of the process of updating both the PIA contracts as well as the ARPA contracts with UT Austin. And so those will all kind of flow through into these totals here. And so on the next slide, there's a lot of numbers here. I'm not going to spend a whole lot of time on this, but this will be available to review later. I think the main thing to point out here is just kind of the grand totals. You can see the variance in kind of total ask by HRI. Another thing I want to point out is this bottom line for UT system administration. That research line there is not because we anticipate doing any research at UT system, but that is the emerging researcher funds that we would be distributing as the executive committee sees fit. So I'll move on to the next. So these are just a few call outs from both TChat, and the next slide is CPAN. I wanted to kind of highlight the work that's being done with both SUD and YAM here. So SUD is continuing with the original 4 HRIs that began on ARPA a while back. And so that's a total of 5.7 million. And then YAM has seen an increase in interest and what folks think they're able to do. And so that new total is coming up to about 23.6 million. On CPAN, you can see here that so I've highlighted both PeriPan and Safety A. PeriPan, every single HRI has decided to participate in some way or another. There are different levels of what kind of service is going to be provided by the HRI, but everyone will have folks on their teams who are able to do resource referrals and do outreach in their community. And the psychiatry time, as Dr. Wakefield mentioned, will be kind of allocated as needed throughout the network. And again, here with Safety A, same HRIs that are currently doing HRI plan to continue, and that total for the biennium comes to about 4.4 million. Next, we'll move into the workforce development initiatives. So in total, between CAP, CPUE, and all of the additional workforce development initiatives that have been submitted, it comes to about $66.5 million that's being spent to develop psychiatry workforce in the state. And so you can see here about 10.6 of that is for CAP fellowships. CPUE is a little over 30 million. And this is including a significant increase in the number of LMHAs that folks are planning to participate or engage in this program. And then finally, the additional workforce development. So this is anything that is not psychiatry. So a lot of initiatives around social workers, LPCs, psychology is included in this. Advanced practice providers are also included in these initiatives. And you can see how that breaks down a little bit more on this next slide here. So just by institution, you can see where folks are planning to implement some of these initiatives and what that looks like. And then I'll move on to the administration budget. So this includes administration, staff and fringe, and M&O here at UT System. And then a significant amount of that is for contracts. So we have the contract with the Center for Health Communications that's continuing. There's a contract with UT Austin to help with the ARPA administration. And then we have our internal and external evaluation contracts, which you can see below there. And then the final slide here is regarding the research networks and the Emerging Researcher Fund. So you can see here the hub totals for the biennium, as well as the total that's going to all of the nodes for those 2 networks. And then again, like we mentioned, the 4.3 for the Emerging Researcher Fund, which brings us to a total of 27.5 million for these initiatives. I have asked the two networks to be available to discuss the methodology for the nodes if folks are interested in going into that. But that's the end of my presentation.
All right, thank you very much. Are there any questions?
Move to
John,
approve the
what a
budget.
fabulous job you've done. And, you know, I know how long our meeting was with you and the team. And just want to say that from the research side, but also in terms of each of the HRIs, this is a Herculean task. And so I'm really grateful to you. Thanks. And your team.
The budget with the option for the central office to make adjustments as necessary to keep it balanced.
Very good. We have a motion, Dr. Polowitz. I have a second by Dr. Nemiroff. Any further discussion?
Just one question. So we could presume the last budget we submitted, that's probably what we're working with for the next 2 years. We can go ahead and plan accordingly. I know we'll get the official documents and when the LLB does its thing and everything, but we're good to go on everything from the final discussion in our last meeting with Jonathan and the system people.
Yeah, so the budgets that have been submitted post meeting with the UT system folks, that's kind of what I've assumed is your final. So if you have other changes that need to be made, that needs to happen within probably the next week. So hopefully by Friday, any teams that have outstanding revisions, if you could please submit that this week so we can get the ball rolling on other approvals.
I just want to reiterate, though, there will potentially be changes in how those are funded, like was mentioned earlier. So Dr. Pliska, if you had some staff that were funded with ARPA, it's possible that funding could shift to GR. So if you're, just from a planning perspective.
Okay. Any other questions?
Lachelle, would you comment on kind of what, I know we had talked a little bit about people making their budgets for Perry Pan, but and maybe not having the perspective of the expectations of the staffing model at the same time. Would you mind commenting on that just so that HRIs can make plans accordingly?
Yes, so as we know with CPAN, the growth of calls, and as has been shown by the pilot sites, the growth of calls is pretty slow at the beginning. I think we've asked everybody for what they think they need from a staffing perspective in terms of psychiatry time. But we have existing psychiatrists available through the 4 pilot sites, and the goal will probably be in the shorter term to set up your referral sources, gather that information, start your outreach and enrollment of those OBGYNs, relying on those pilot sites to help offer the services until our call volume gets to a point where we may need to increase the number of psychiatrists from a cost perspective. I would imagine, Dr. Wakefield, that you're going to be working closely with all of the teams as a medical director to help provide that guidance on, what are the numbers looking like. We do want to give ourselves enough time to ensure we're recruiting. We know, as you said, there's not a whole bunch of people with that specialty. And so I know you have some plans for the training. We want to make sure that we have a pathway to recruit, but at the same time, we don't recruit a whole bunch right at the starting gate and then not have the work or the volume of work to keep them engaged. So I would envision that we would start doing those planning sessions with the HRIs probably starting fairly soon so that they understand what are next steps for them. But we don't want to exclude budget from folks in case we do need to recruit for those. But I think we just want to be thoughtful in how we're applying the funds to match volume.
Yeah, absolutely. I think I was just saying maybe it looked like there were submissions for perinatal psychiatrists over our plans from some of the HRIs when you total it up over, looking more like that 12 across the state. And really our expectation is that we likely don't need any more than 6 or 7. And so we just want to have an engaged process of thinking through that with the teams. And we will absolutely, Pan Central from the COSH will be engaging each of the HRIs about what, and we'll start those meetings very, very quickly about what everyone's capacity is and where you want to go and kind of when we'll staff up for that. But yes, we wanted to have that conversation here briefly.
So I think it'd be good to have that conversation again. But I am also encouraged that each HRI is participating in it, and that there'll be people boots on the ground at each HRI. And hopefully, as this continues to grow, we'll be able to increase that capacity at each of the HRIs, because it is a statewide need, and want to make sure that we have that statewide presence in providing a critical service to the state of Texas. And as we also are efficient with the dollars and stewards of the dollars. Dr. Trivedi, and then Carol, and then Stephen again.
Small point, I think Jonathan should get some kind of TCMHCC award for being patient and yet very persistent and laser focused on details. So thank you, Jonathan.
All right, very good. Carol?
So I just wanted to recognize, David, your leadership in all this. Looking at the budget, it just knocks me over about a program that takes that's good enough to receive this amount of state money and fit into both academic and educational and legislative requirements. And I just think it's fabulous, and I'm pleased to be a part of the process. And thank you and your team for doing all this.
Thanks, Carol. No, it's obviously a team effort, and I'm surrounded with very competent people that are really working hard on this. And it is pleasing to see that 5 years ago, when a lot of us were meeting before the consortium, a lot of the things that we were thinking about are being actualized in this budget. And the conversations we had related to workforce and the research and the provision of care. And I guess the other point I was going to make is that there still are some ARPA dollars, and as we'll be smart about them. But if there's some additional needs that are consistent with what the legislature has asked us to do, we would like to continue to have those discussions. The other part about workforce is that we have these workforce initiatives. We've also tried to incorporate trainees into the various programs and TCHAT. And that's what it's going to take if we're going to get out of this current situation in the statewide mental health professional shortage areas that we have in the state. So thanks everyone for the ongoing work. Stephen, Dr. Pliska?
Yeah, I just wanted to, on the Pan, if I heard correctly, you're suggesting we only staff up for the ancillary staff and not look at having our own psychiatrists do it, that you want to use the current group of psychiatrists to actually do the consults? Was that the takeaway, or did I misunderstand?
I think Sarah's saying that there's going to be conversations, but we're going to support your needs, and especially in major metropolitan areas where you have demonstrated needs. And I think this is part of building the workforce you need. And so we will be working with each of the HRIs to make sure that you get what you need to move forward. And several of the HRIs have said, we're going to participate, but we're not ready yet to have a perinatal psychiatrist. And so we're not forcing those institutions to hire a perinatal psychiatrist, and they're partnering with other institutions. But if an institution can demonstrate that they need it, again, I think that's part of building the capacity statewide that we're going to need for the future. But we need to have that dialogue occurring to make sure that we do it in a uniformed way.
Very good.
Okay. Thank you. Any other comments? Okay. So I had a motion by Alan, a second by Dr. Nimroff, but he had to step out. And so I might have to I got a second one from Dr. Nimroff and Carol. Any further discussion? Hearing none, I'm going to call the question. All in favor of approving this as a preliminary budget? And as Dr. Polowitz noted, with us having the authority to make minor adjustments based on ongoing discussion with the HRIs please signify by saying aye.
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 Anyone that's opposed, say nay. Did anyone abstain? So what I hear for the record is that we had unanimous approval for the budget and have the authority to move forward with ongoing dialogue with the HRIs and minor adjustments as needed. All right.
Right.
Very good.
Great.
So I'm just checking the agenda, and I think that was the last one. Luann, anything else we need to discuss?
Yes.
Okay.
This is in relation to the next meeting, which is going to be held on August 21st. As I mentioned at our May meeting, we went through and adopted changes to the governance plan. And at that time, we talked about the governance plan being very clear about membership on the executive committee. And on June 13, I sent the executive committee an email letting you know that there are vacancies for the 3 nonprofits that focus on children's mental health. Currently, those are the Hogg Foundation, the Texas Council, and Meadows Mental Health Policy Institute. Those 4-year terms expire August 31st. So any of those nonprofits out there that want to either reapply to be on the executive committee or apply to be on the executive committee can do so prior to July 31st. And that link was sent to you, but I can resend it after this meeting. The 4-year term for the administrative support entity, which is currently the UT system, is also expires August 31st. And so any entity that would like to apply for that can apply for that. The 2-year presiding officer position is also up for re-election effective September 1st. That individual has to serve on the executive committee. And the 4-year term for a representative of a hospital system in Texas also expires on August 31st. So we are accepting those applications online. And again, I can post that link or resend that link to you. It is also available on our website. So I wanted to remind you of that. So we will be discussing executive committee membership at the August 21st meeting and voting in members to take effect September 1st. Also in our governance plan document in relation to that meeting on August 31st, we had mentioned that the Educational Service Center, there is a representative, the legislature voted for 1 representative of an Educational Service Center to also participate as a member of the executive committee. So we will hopefully hear from TEA at the August 21st meeting about that. So wanted to talk with you about that meeting.
Very good. Any questions? Again, this is just basically us following the governance document that we approved in this committee, that there's terms for the positions that aren't the HRIs, and including the presiding officer and the administrative support entity. And so if there's another entity that wants to apply, they are allowed to apply, and then it'll come to a vote by the executive committee. And same thing for the non-for-profits and the hospital representative. Okay. Any further discussion? And so we'll send that out again to make sure that you are aware. Again, would hate for somebody that wants to continue to be part of this or wants to be part of this to forget to apply. But we need to make sure we follow the rules. All right. With that, are there any other things consistent with our agenda that we forgot to discuss?
All done.
All right. So Carol, is that a motion to adjourn?
I make the motion that we're all done. Yes. Thank you, David.
Is there a second to all done motion? Dr. Liberzon, all in favor? Aye. All right. Thank you all.
Bye-bye. Thank you.
Talk to you in a month. Thanks.
Bye.